over it, uh, ulcer over it, which was initially small in size of about 2 to 3 mm when he noticed, and which was gradually progressed to the present size of approximately 1 centimeter over 3 to 4 months. The ulcer is not associated with any pain or not associated with any discharge. There was no difficulty in swallowing or speech, no history of difficulty in opening mouth, no history of any ear ache or cold or cough in the past, and no history of any excessive salivation, no history of loss of appetite or loss of weight, and there is no history of trauma or any dental intervention in the near past. Coming to past history, there is no history of radiation exposure to the head and neck, and not a known case of diabetes, hypertension, or asthma. There was no surgeries in the past, and no history of IST or pulmonary TB in the past. Coming to personal history, he takes a mixed diet with sleep and appetite normal, bowel and bladder habits normal. No known allergies are seen. He's a known kidney chewer since 4 years, and he's a known smoker with 10 to 12 cigarettes per day since 4 years of 2 to 2.5 pack years. He's an occasional alcoholic since 4 years. Next. There was no relevant family history of head and neck related cancers in the first degree relatives. Next. History.
I think this is a long case or a short case?
There are two things before you want to go to examination I would like to tell. I'm Dr. Narayan from Department of Surgery, Ramaiah. In the history of present illness, you have told twice, thrice, patient developed, it is only patient noticed. Okay, later on you told once noticed.
Yes,
it's
sir.
always patient noticed. Number second thing is occasional alcoholic does not go well. It's a patient consumes alcohol either in moderation or occasionally. Alcoholic is an addict. So please refine your history next time when you do the presentation. Okay.
If you go back one slide before. Yeah. So along with all these things, you have to mention what could be the etiological factors for this tumor. If you don't mention the etiological factors, you cannot prevent further secondary cancers or other issues. So what are the etiological factors that you would like to look into for this pathology?
Any history of any history of trauma or any sharp tooth or anything?
What are the you know of?
Sepsis, smoking, spirit, and syphilis.
And you mentioned sharp tooth.
Sharp tooth.
Syphilis is not very common these days. When we did our MBBS, it used to mention about syphilis, but now it is not seen. What is the reason for this excessive salivation? Salivation. Why does excessive salivation happen?
Yes, sir.
Do you know the answer?
Maybe because of local irritation.
It is because of the pain.
Tongue or
pain.
Yes, sir.
What is the reason for earache?
Earache, maybe
for everything there must be a reason. That is why.
Maybe because of any ear infection which can spread to
I will tell you. Earache happens due to these following reasons. The lingual nerve supplies the tongue, right? Yes, or no?
Yes, sir.
Yeah. So a branch of the mandibular nerve also supplies the external auditory canal. So there can be referred pain. Second, if there is extension to the base of tongue, base of tongue is supplied by glossopharyngeal nerve. The tympanic branch of glossopharyngeal nerve is also known as Jacobson's nerve. That can result in earache. Referred pain. Third is if there is extension, if there is some lesion in the pharynx through the vagus nerve, the Arnold's branch, it can refer to the ear. If there is a lymph node in the neck, there can be referred pain because of the greater auricular nerve. That is to the external ear. main reason for referral of pain is either lingual nerve irritation
Lingual
or
nerve.
glossopharyngeal nerve irritation.
Sir, Venkatachala sir, this is a case for the 25 minutes.
Okay.
Now,
Please
Dr.
proceed.
Gurushantappa sir, I welcome Dr. Gurushantappa sir.
Yeah, thank you.
Yeah, sir, Santosh sir, anything to say on this history, sir, at this level?
Is there any, was he having any pre-malignant lesions previously identified by?
Whitish patch. Then
Oh.
whitish patch was there initially.
Yeah. Okay. Okay.
Yes.
Okay. I think he has mentioned mostly about smoking, alcohol, kine, etc., which are possibly the precipitating factors for the development of malignancy. Also, maybe he can add one sentence that he doesn't no other swelling in the neck, complaining of any swelling in the neck. Okay, fine.
Yes, sir.
Fine. Let's move to the physical findings because it's a short case.
Yes, sir.
Slides.
Yeah, proceed with the examination.
Coming to examination, patient was examined in a well-lit room after taking an appropriate consent in the sitting position. Patient was conscious, oriented to time, place, and
I
person.
think you can go
He's
to
moderately
examination
built.
findings directly, no? Because of the
Yes, sir.
paucity of time. Yeah, please.
Okay. Coming to examination. Next, inspection.
Go ahead.
Next slide.
No, previous slide.
Previous slide you present.
Just to note that facial spelling is wrong. Facial is different, facial is different.
Yes. Coming to local examination, inspection. Facial symmetry is maintained. Mouth opening is normal and poor dental hygiene noted with nicotine stains over the teeth, and there is no loss of teeth or halitosis noted. Retromolar trigon is normal and floor of the mouth and opening of salivary glands is normal. Submucosal fibrosis seen on the left side of the buccal mucosa, and tongue protrusion and movements are normal. There is a single ulcer of 1 into 1 centimeter size present over the right lateral side of the anterior 2/3 of the tongue, with granulation tissues, floor and irregular margins, and there is no discharge seen. Surrounding the lesion, there is a leukoplakic patch of approximately 1 centimeter medially and 2 to 3 mm laterally. Coming to palpation, inspector
The
findings
floor
are
of the
confirmed.
ulcer, you say granulation tissue. Excuse me, I'm Dr. Narayan Swami.
Yes.
The floor of the ulcer, you say it's granulation tissue. I don't think so. We should use granulation tissue. Granulation tissue is a healing tissue. Ultimately, what we are talking is about malignancy.
Malignancy.
Necrotic tissue you will get to see.
Yeah. What Dr. Venkatachala is telling is correct, right? So
Yes.
please don't use, people often use this as granular, whichever is red is granular tissue. No, it is not. Okay.
Yes. Okay. Coming to palpation, inspector findings are confirmed. A single ulcer of size 1 into 1 centimeter, non-tender, not bleeding on touch, hard in consistency with irregular margins. Surrounding area is normal, and the soft palate shows symmetrical movement on mouth opening, and movement of temporomandibular joint is normal. Scalp, ear, nose, and cervical spine examined and are normal, and there are no palpable cervical nodes.
I would like
And
to,
systemic examination, respiratory system.
if you go back to the previous slide,
Hello, sir.
go back, yeah, here, the palpation findings, please. So you have to mention if
Yes,
there
sir.
is any induration at the base of the ulcer. The base is towards the substance of the tongue, medially. So if there is any induration,
There is
invasion,
no
makes
induration.
invasion.
I agree. I just want to add with Dr. Venkatachala. It is not that you do consistency of the ulcer. You never do the consistency of the ulcer. You only look at the induration of the base of the ulcer.
Okay, sir.
Okay.
Consistency is very difficult. There will be pain. Unlike
Yes.
epithelioma or a squamous carcinoma on the skin.
The other important findings that are missed is whether it's crossing the midline, whether it is getting into the floor of the mouth, All these things are very important palpatory findings. The induration, it makes a difference.
Also,
no induration.
yes. So in the oral lesions, once you examine the oral cavity, you have to say that the rest of the oral cavity is normal and the oropharynx also must be examined. If you can do a indirect laryngoscopy,
Okay.
it is good. You can mention, otherwise at least whatever you see in the oral cavity, oropharynx, you must mention. Okay, I think you can proceed, sir.
And even the
Okay.
induration, you have to tell exact amount of induration around the ulcer is also extremely important. That when we try to operate
Okay.
the case, okay, because that induration gives us a or a microscopic this thing, okay.
Depth of the induration is
Yes,
also used for staging.
He has actually said that there is no induration, which is difficult.
Yeah, correct, sir. You mentioned that. Okay.
Very difficult to believe with a malignant ulcer, unless it's so superficial an ulcer.
Correct. Unless it is a flat ulcer.
Yes.
Not
something like a verrucous carcinoma or something of that kind, but it's more of an ulcerated lesion.
Right.
So
Right.
having making a commitment that there is no induration is hard to believe. Anyway,
yes. I mean, patient is not having any pain or any, only
Sir,
that
please
leukoplastic back
proceed.
is sticking, sir.
Proceed with
Yes.
the further.
Systemic examination, respiratory system, bilateral air entry equal and no added sound. Abdominal examination, soft, no organomegaly. CNS is normal, musculoskeletal system normal. Coming to summary, he is a 35-year-old gentleman, known kidney chewer and smoker with ulceroproliferative growth with surrounding leukoplakia over the right side of the tongue since 1 year, which is non-tender without any lymph node or distant metastasis.
See, there are two things in
Coming
this
to
line. In this line, see, you use the word gentleman. That is a much respectable word than calling a male or a female. Gentleman and lady
Yes.
is a better option. Second, you always write it as right lateral border of oral tongue or right side of the base of tongue. Okay,
Yes.
not the right side of the tongue, right lateral border of oral tongue. Okay.
Do you understand
Okay.
the reason why Dr. Venkatachala said so?
Yes, sir.
Why?
Sir?
Did you understand why Dr. Venkatachala
Yes.
specifically mentioned that you talk about oral tongue? Did you?
Oral tongue.
He mentioned
Yes, sir. Posterior third of the tongue. It is involved.
That is a different part. It's not in the oral cavity,
Yes,
isn't it?
oral cavity. Yes. Coming to provisional diagnosis, this is carcinoma of the tongue over right lateral aspect of the anterior 2/3 of the tongue.
How would you like to proceed?
First, I would like to do the imaging, sir, and
Would you not provisional diagnose the
biopsy.
PNM here on after diagnosis? Just given
No, sir,
diagnosis.
because
Can you not put
no, sir.
further
TNM
or a
classification
clinical
according
TNM?
to latest edition, they have included depth of invasion. So depth of invasion we can't say clinically. So after imaging only, I think we should.
Which imaging will give you the depth?
Depth maybe MRI tongue, MRI oral cavity. Or
your clinical examination is a better indicator, roughly approximately, and the pathological report will confirm that better.
Okay.
So you must confirm your diagnosis.
Clinically depth.
No, you have to confirm your diagnosis before any other tests. So how do you confirm your diagnosis?
Venkatachala?
Yes, sir.
Biopsy.
Yeah, if the depth of the invasion in a superficial malignancy of the tongue, you could have pinched the base between the fingers. You would have assessed the induration as well as the depth approximately.
That's what we told him.
Like
So
a
he couldn't appreciate.
superficial one. Yes,
He
right?
couldn't appreciate. Correct. So we need to confirm the diagnosis here. How would you confirm?
He has categorically mentioned there is no induration. That's if he has mentioned this discussion on all these depth of invasion, etc., would not have arisen. Now that there is no induration, even the diagnosis may be doubted. Okay.
We'd like
Proceed, doctor.
Edge biopsy we can take, sir. Edge
What
biopsy
biopsy
to
is it?
confirm the diagnosis.
How
Edge
do you do
biopsy.
the biopsy?
Edge of the lesion with the normal tissue. We'll take it for biopsy, sir.
No, how do you take the biopsy? What is that particular word used for the biopsy? Punch biopsy under local anesthesia from the edge of the lesion. Correct? Hello?
Yes, sir.
Punch biopsy from the
Sir,
edge of the lesion under local anesthesia.
Yes, sir. Punch biopsy. Edge of.
If you can turn your video on, it will be better because you're presenting.
Yes, sir.
So what did the punch biopsy show?
Actually, biopsy patient was not willing, sir. So we got just an MRI of the neck.
What other biopsy can you do instead of
After that, patient has lost follow-up.
No, you leave it. We'll go for the discussion. If not punch biopsy,
We can do imprint biopsy.
What other biopsy is available?
Imprint biopsy we can do, sir.
No, not imprint biopsy.
Imprint
you do
biopsy
an
we can do, sir.
incisional biopsy from the edge of the ulcer under local anesthesia.
Yes.
Now the incisional
Yes.
biopsy is showing as squamous carcinoma grade 2. What would you like to do?
We should do the staging, sir. Staging according to the stage treatment differs.
What investigation would you like to do for staging?
MRI of the oral cavity with the neck to see for the lymph nodes. Since clinically I couldn't
Any other
find
investigation, cheaper investigation available other than MRI of the neck?
ultrasound neck.
Ultrasound neck is a reasonably good option to evaluate the neck in presence of N0 neck.
Yeah, Venkatachala.
Yes, sir.
Prashant, what is the idea of doing MRI neck for this patient? What is your intention?
MRI neck, since it's the tongue, the soft tissue invasion, and it will be better with MRI, sir.
So you already know that there is no induration.
You mean the tongue tumor is invading the neck, and that's what you would like to know from doing MRI neck?
No, sir. Any extension?
No. This case,
Yes.
which is able to protrude the tongue out, and the lesion is limited to the lateral border. What is the idea of doing MRI neck?
Did you want to do an MRI of the neck, or he wanted to do an MRI of the tongue? That is, there is a difference between the two. What did you really want to do? Oral cavity?
MRI oral cavity with,
yes.
With neck.
See, if you ask me, there is no need for MRI in this case because it is very clear that it is a superficial lesion and a small lesion. You won't get any extra benefit from that MRI. Ultrasound of the neck, except if the ultrasound shows abnormality, what would you like to do?
Did you understand? Did you understand, Prashant? Just because there is a carcinoma tongue, you don't have to go always for an MRI.
Always.
You don't have an induration. It's a highly superficial lesion, maybe very early carcinoma, and there is no induration. You can do away with a, an MRI. But then ultrasound evaluation of the neck would bring out possible nodes, clinically being an N0. Isn't it? Fine.
Rajan sir, we are left with 5 minutes, I think.
5 minutes more.
Yeah.
Just I would like to mention 4 points are important in the nodal disease. If there is nodal disease, you will see intranodal echoes, hypoechoic lesions, which shows that there is metastatic. The hilar fat gets obliterated. The lymph node, instead of being bean-shaped, can become rounded. There can be perinodal fat infiltration. These 4 points you must make.
Guru Shantappa sir, can you summarize the management?
Yeah, presentation wise, I did not see protrusion of the tongue you should have mentioned, which will tell us that yes, is there any ankyloglossia or hypoglossal nerve involvement, which will be depicted by mentioning this point. And in the biopsy diagnosis, yes, one punch biopsy, second is the incisional biopsy. Definitely incisional biopsy will give the diagnosis. And you should have mentioned MRI tongue, like Santosh sir mentioned, the MRI tongue, if the imaging would like to do. And nowadays, even a good sonography of the tongue itself will give us a lot of information. And if there are neck nodes, that is sonologically to find out nodes. If there are nodes on sonography, definitely that becomes an indication for a CT neck, CECT neck, for evaluation of nodal disease in a case of CA tongue. So don't mention the MRI neck for a nodal evaluation. If there are nodes clinically or sonologically, the next investigation would be CECT neck to know the nodal disease and the base skull disease secondary to deposits.
Yes.
And treatment, I think we did not discuss. Definitely, yeah. What would be the best treatment for this man if it is a well-differentiated squamous cell carcinoma of this size?
Since it is 3 centimeters, it will come under T2 or T3, sir. If depending on depth of invasion.
How can it be T2, sir? If the lesion is 1 centimeter.
2 to 4. Sir,
no,
1 centimeter of the ulcer.
Your lesion is 1 centimeter size. How can it be
1 centimeter of ulcer and surrounding
leukoplegia is not included in the staging, sir.
That is why the induration, everybody was looking at the induration. Now you have categorically mentioned that there is no induration. It's a very superficial lesion.
Since it's pre-malignant condition, you shouldn't include leukoplegia.
Leukoplegia is a pre-malignant condition.
It will become 3 centimeters.
No. It is not included. You only look into the ulcer, the edge of the ulcer, and the
Prashant.
Sir.
Once 3-4 of us are mentioning that importance of induration, and we are asking you to give a surgical procedure required. Best is to accept and mention either you can mention it as a wide local excision with 1.5 centimeter margin or hemiglossectomy with a justification.
Yeah.
We don't use the word hemiglossectomy because hemiglossectomy means half of the tongue, including the base of tongue. Wide local excision is a correct terminology that you have to mention. Along with wide local excision, what would you like to do?
If we can close it, primary closure we can do, sir. Or we can close it with a graft.
Don't leave it that you have managed. No graft is needed in this case. Primary closure also we don't do because we want the tongue to be mobile rather than getting suture to the floor of mouth. Okay, it will heal with, on itself. Don't worry. Anything else you want to do? Is that the wide local excision is enough or something else has to be done?
Yeah, please conclude, sir. I think you just enough.
You have to address the neck also. The neck management, N0 neck. You will do a anterolateral neck dissection, means level 1, 2, 3, and 4. And if there is involvement of the neck node, you do a modified neck dissection, type 1 or type 2.
Yeah. Thank you. Thank you.
Yes, sir.
Is there a need for MRI of the tongue? That means every cancer of the tongue, you will do MRI?
Not in this case. If there is induration, depth invasion, if there is beyond the midline, those conditions where you know that you will need to do some neoadjuvant therapy, assess the response to treatment in those conditions.
Correct. So not in this patient, right?
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir. Thank you, Dr. Prashant Sai. So good presentation. Good presentation. I thank all the moderators for this discussion. Now we are moving to the most important part of this today's program is Dr. K S Shekar State Level Surgical Quiz. So, as the legacy of the Surgical Society of Bangalore, every year as a part of the CSEP program, we conduct the state level surgical quiz by Dr. C.S. Rajan, sir. So, over to you, sir.
As Dr. Shekar logged in.
Share my screen.
Yeah, please share the. Please share your screen, sir.
As Dr. Shekar logged in.
Yeah, you will log in by 7 o'clock, sir.
Okay. Welcome, Dr. Rajan, sir.
Yeah, is my screen being shared?
Yes, sir. We have to go for full screen. Yes, sir. Proceed, sir.
Right. Good evening, everybody. And it's come to that time of the year where the little bit of brain is tickled with some questions to see knowledge and share knowledge. It's an annual event of the Surgical Society of Bangalore conducted for the state chapter to find out the best pair of quizzing teams in the state. Formerly, they used to be sent through to the National ASICon to represent Karnataka, but now we will be having it only to find out who's the best in the state with good, attractive prizes. The quiz is open only for teams from Karnataka, and they have been pre-registered with Dr. Lakshman, who has sent them a link, and this link will open at 5:30. So teams, please move to the link that has been provided. It's a Google Sheet link, which will open for answering exactly at 5:30, which is 1 minute from now. The others who are not participating are invited to be with me on this screen so that we can take part in an open quiz. You can be a pair or a team, and you will be able to answer the questions which I put up for the next half an hour. It's a fun quiz. It is some knowledge and some entertainment, but nonetheless, this is how we do it when we are fully electronic. Dr. Lakshman, are you ready?
I'm going by my computer clock to be precise, which is synced with the World Wide Web.
All right.
So it's reading 5:27,
Right.
and so it will be another 3 minutes before I switch it on. 5:28, so it will be another 2 minutes when I'm ready. And as you rightly said, I want the registered candidates to be focusing on the Google form rather than the quiz that Dr. Rajan is conducting. That's for the non-participants. Thank you.
Yeah, thank you. A brief history of this. We have great index to Dr. K S Shekar for having put up this quiz as his baby in the year 2000. And from then we have been regularly conducting it. It is both at state and national levels. Dr. Shekar will be joining us for the finals at 7 o'clock. Two other very important contributors have been Dr. C.R. Balal and Dr. K. Lakshman, who gave us the impetus to start this. And for a few years thereafter, I have been taking it on. It is a challenging thing to do, and it always keeps me on my toes so that I can have some amount of knowledge gain as I do it. So there is an individual interest in it. The teams that are not getting the link and who are still available can join this quiz, which is only with you will type. Chats are being monitored by my colleagues, Dr. Nishant, Dr. Hoshni Mubarak, Dr. Manish Joshi, Dr. Senthil Rajan, who is sitting in Aberdeen, and he's also going to be part of the monitoring team. And of course, Dr. Niranjan. So these are the 5 people who will be helping me. We will note the quiz, first correct answer in the box, and then we will proceed. Dr. Lakshman, tell me when you're exactly starting, then I'll start from this side.
Yeah, I have started now.
All right. Okay. Here we go. The main quiz is started. That will run exactly for 15 minutes and shut. And I will be taking you through another 15 minutes. That's for half an hour, so that Dr. Lakshman gets time to collate the answers. This is from 5:30 to 6 o'clock. It is for the locals and non-Karnataka people and faculty. Please, all of you also are most welcome to give your answers. It's on the same Zoom platform as is going on now. Give your device a name so that we can identify you. There are 15 questions which are coming as picture sets of videos. It will play for a certain time, and type the answer in your chat box. The time of the chat box open for each question is mentioned on the slides, and it will vary between 20 and 40 seconds. There'll be 10 or 20 points, which is again indicated on the slide for the single first correct answer. If no answer is given in 40 seconds, we will move on to the next question. I hope these instructions are clear. There's a winner and a runner-up position for prizes. These are my monitoring teams I mentioned. And I will just give you the hint that video clips will be played twice. So are we ready? Are we set? And here we go. This is a sample question. It's not the main question. It is just a sample for you to connect the pictures, which are going to come up now, for 5 non-medical words. And the pictures are please connect these pictures to give me an answer of 5 non-medical words. The chat box is, in the sense, it's not for the main quiz, but this is how the questions will appear. There are 4 pictures. Please connect them. Chat box open for 4 hours. Dr. Nishant, will you please tell me if anybody writes up in the chat box?
Sir, Niranjan here. I am also there.
Niranjan?
Yeah. So only one question has come in, not related to this. Probably they have not received the link of the quiz, they're telling.
Yeah, but they may not have registered. All registered people have got it. Any other answers?
No.
No answers.
No one.
No answers.
No answers. All right. Okay. Unfortunate. Nobody's tried to trial it. But this is the answer. The answer is that's Liechtenstein. These are low tension cables. That's a fishing net or a mesh. And this is a gene with multiple patch repairs. So the answer that I was looking for is Liechtenstein's tension-free mesh repair. So this is how the quiz is going to go on. I'll move on to the first official question of the quiz. Please note, connect the pictures with a single word answer. Chat box open for 30 seconds. And for 10 points, the pictures are. Can you see the pictures? There's a box, there's some chest X-ray, there's some flowers, there's something like a handle, there's something like a wheel. Single word. I'll give you one clue. It's an anatomical word. Anatomical part.
There is one answer, pantaloon hernia.
No, it's not the right answer.
Sternum.
Who gave sternum?
Hemavardhini.
Yeah, very good. That's the correct answer. The answer is, it is the box area of the chest involving the sternum, sternal wires. These are gladiola flowers, which are the middle part of the sternum. Sternum gets hurt in chest, steering wheel injuries, and manubrium is a handle. So the correct answer, sternum. So Dr. Hemavati gets 10 points. Moving to the next question. Again, connect with a single word answer. These are the 5 pictures to connect. Some symbol, some toes, some limb, some body part, some probably skin area lesion. Can you connect for a single? The chat box open for 30 seconds, 20 seconds more.
Ischemia.
No, not the right answer.
Dry ulcer.
Ulcer, not the answer.
Clot.
Clot, no. So nobody
Gangrene.
gets that. Sorry, gangrene, no, not come. Where's the gangrene in the lower picture? So that's not the answer. The correct answer is, nobody gets that. The hint was, think of Pfizer, but Pfizer, it's already too late. These are blue toes, this is blue leg, cerulea, dolens, blue dot sign, and that is maggots of the blue bottle fly. The answer that I was looking for is a simple color word, blue. Moving to the next question. These are 3 emojis. There's a bit of a naughty question. I'm giving you the clue. Chat box open for 20 seconds only, 10 marks, 3 emojis. Connect them and give me a single word answer. It is a definition of something. Just 20 seconds, quick one.
Diabetes mellitus.
No. We'll be happy with diabetes, man. Anybody else? 5 seconds more. As I said, it's just characteristic of me, which is naughty.
Satiety.
Satiety, no. The 3 H's of health is when you feel hungry, when you feel horny or love-filled, and happy. So the answer I was looking for was health, which is defined as a crown on a healthy man's head, which only a sick man can see. Again, nobody has scored. So still Dr. Hemavati leads with 10 points. Okay, another common word to connect. This is the chat box open for 30 seconds, 4 pictures. Connect them commonly. I'm giving you a hint, think trauma. 30 seconds. Anybody coming in the chat box?
No one so far, sir.
No one. Another 10 seconds.
No. Seminoma and embolism are the
Embolism.
answers.
No.
Embolism, fat embolism.
I've said
Fracture
think
of
Fracture.
trauma.
Arvind Patel, fracture.
Wow, my God, the word is fracture. Yes, Dr. Arvind Patel, congratulations. That is the true answer. The penis can fracture, pancreas can fracture, bone can fracture, and we use a finger fracture technique for the liver. The answer is fracture. 10 points to the chairman of state chapter. Well done, sir.
Thank you.
Right. Another single word answer for these pictures. Chat box for 30 seconds. Connect all these pictures for a single word answer. Can you see an
Dilated
MRI? Sorry?
Dilated cyst.
No. Where's the cyst in the first picture? Another 15 seconds for the chat box.
Halo.
Halo. No, it's not the halo.
Abscess.
Abscess is not the abscess.
Inflammatory CA.
What is the white dot in the first picture on the top left-hand corner? White.
Node. Coin.
No, I'm very sorry. These are the things that I want you to look out. I've circled all of them, and all of them are prostheses. There are various forms of prostheses. This is a testicular prosthesis, breast prosthesis, gastric band prosthesis, and a acrylic balls prosthesis to obliterate space in the chest that is called Prumbage thoracoplasty. There is a bonus question on this. Everybody for just 5 points and only 10 seconds on the chat box. What prostheses are these? The two blue-eyed things. Any idea what those
Silicone.
Silicone in lines? Why?
Support for the bra.
Ah, absolutely. Bra prostheses. Yes. Who's that support for the bra?
Lakshman.
Lakshman. You know your ladies very well, Dr. Lakshman. Yes, that is the underwire prostheses for the bra. Moving on. Now a little more clinical. I'm giving you a picture. It's a 27-year-old male with sore throat for a week. The head and neck CT scan picture is given. I want the diagnosis. Chat box, 30 seconds.
TB is an answer.
TB.
No, not yet.
Tonsillitis, another answer.
Tonsillitis, not enough.
Peritonsillar abscess.
Yes. Who's that? Peritonsillar abscess?
Our
Venkat.
president.
Sorry?
Venkat.
Venkat. Arre. Cancer chap is thinking of benign disease. Very good, doctor. This is very classically Quincy peritonsillar abscess. 10 marks to the president of Surgical Society of Bangalore. Chairman also, president also. Very good, guys. You make me feel very happy that you're answering. Next image. So that's a peritonsillar abscess. A clinical picture, it's a spotter. Chat box open for 30 seconds for 10 points. What is this? The story is that it's a 32-year-old male. He had a left cervical rib excision done 4 weeks ago and presented with this clinical picture. There's a CT scan done. I'm sorry, that picture is a little blurred. I think I shook when I took it long ago. But what is the diagnosis?
Aneurysm.
Aneurysm, no.
Pseudoaneurysm, wrong.
Thoracic duct leak.
And again, very good. What is the leak called, sir? You're right.
Chylocele.
Chylocele, the word that I was looking was chylocele, chyloma. Any one of the thoracic duct leak is the right thing. That is exactly what it looks like. And the story tells you a lot about what the picture is. So that's very nice. Thank you. Congratulations, Doc. You're in the lead now.
Thank you, sir.
From the pathologist desk, this is a histopathology slide. I want which one the tumor is and what is the pathology. I want the particular name for that tumor. And I'm going to give you a hint. It is a cartoon character tumor.
Orphan Annie, right?
Yes, sir. Again, orphan Annie hide cell. Yes. Have you typed it in the box?
No.
No, sir.
Then he
Dr.
doesn't get
Aarti also
Bala.
typed the same time.
Aarti Bala answered correctly.
Who?
Aarti Bala.
Aarti Bala. Very good. That is orphan Annie tumor, papillary cell carcinoma thyroid, and the orphan Annie tumors are the nuclei, which are very clear in appearance and look like little orphan Annie's eyes. So this is the little orphan Annie tumor, papillary carcinoma of the thyroid.
Jyoti also answered. Jyoti S was the first. No, Anjali AB was the first one. Sorry.
Yeah, you please note who got it first.
Yeah.
Here's another
Anjali.
clinical picture. 5-year-old male presents this. What's the diagnosis? The chat box is open for
Raspberry adenoma.
Raspberry adenoma. No. I want
Umbilical
something more.
Omphalocele.
No. 5 years, man.
Umbilical granuloma.
What are the causes of umbilical granuloma and raspberry and other things?
Urachal cyst, sir.
Urachal cyst not there. Can you write it in the box, please, so that we know who's done it first? Okay, I'm closing it because the 20 seconds is over. This is the vitellointestinal duct at the umbilicus. And this is Dr. S. Ramesh's case. So I take it
Arvind Patel just gave the answer before you were about to show the slide.
Oh, okay, then let the two chairman and president fight. Give him 10 points. Yeah. Right. Now in the operation room, okay, what is being shown? It's only for 20 seconds. I'd like students to take this rather than the seniors. Seniors will get it. But if nobody gets it, you can also try at the end of 20 seconds.
Khaled's triangle, Khaled.
No.
Critical view of safety.
Who said
Manya
that?
Om Kumar.
Manya Om Kumar gets it. This is the 4-word answer that I was looking for. And it is a critical view of safety. Gallbladder dissected off the bed. Then you look at the artery and the duct and you get the picture. Right. Now we got into what's going on. All right. It's a procedure that is going on. This is for 45 seconds. There are 9 pictures in it. What's being done? What's going on?
Rajan, I'm interrupting. I'm sorry.
Yeah.
It's 5:45, but I've had only 2 responses. So if you could just say, I will close it in another 30 seconds. Students must submit the form in whatever state it is in, please.
Yeah.
Yeah.
Just to break off, please, students who are there on the quiz, kindly submit your answers in the next 1 minute. We have already exceeded the time. You have to hit submit then only your answers get logged in. Without submit, none of what you've answered is noted. Please hit submit and submit your answers in an as is where is form, however many you have answered. We need you to submit, hit submit, then only you will be evaluated and calculated and scored. Another half a minute from now.
So Venkatachala sir has given an answer poem.
Oh, very good. Dr.
That was the
Venkatachala
first
sir,
answer.
it's called not poem, it is G poem. Okay, it is gastric poem, the gastric peroral endoscopic myotomy, where you're cutting and incising at the level of the pylorus. And that's the incision that is made, and that is the tunnel that developed, and there the muscles are being divided. This is the widened pylorus at the end of procedure. It's closed by a few clips, and some months later, you can see that that is the scarred area is healed, and when you look at it, the orifice is opened. So this is done for gastroparesis. The correct answer is G poem and not poem. Whoever's written G poem, then they get it.
No one, sir.
No one. Okay, moving on to the next question. This is the question. What has happened Whipples, day 10, nasogastric feeds going on. The drainage tube is something like that. They had to re-laparotomize the patient, and this is what they saw.
Pancreatic duct fistula. There's one answer.
No, that's not the right answer.
Anastomotic leak.
That's not the right answer.
Saponification.
No, that's not the right answer. NJ feed, tube feeds going on. I'll play the thing again as I promised. It will be played twice.
Peritubal leak.
Not peritubal leak.
GJ leak.
Not a GJ leak.
Necrosis due to
Being pulled out now, pulled in now.
Tube site perforation.
Who said tube site perforation?
One sec, sir.
Akshaya.
Sure. Well, I'm greatly indebted to Dr. Santosh Abraham for this case. This is his own personal case he shared with us. Sir, please apologize for taking and using this without your permission, but it's for the case sake of teaching. This is the drainage tube fluid that looked very much like the feed of the patient through the NJ tube, clinical condition deteriorating, and that is why a laparotomy was done, and this is what they found. So it is the correct answer is the nasojejunal tube perforation of the jejunum. If somebody has a tube perforation of jejunum, I'll give it to them. All right, we move to the next question. It's again for chat box. This is for 20 points. The chat box will be open for 30 seconds. I'm playing the first time. I'm playing it a second time.
Fitzgerald, violin string adhesions.
No, can you concentrate on the right half of
Trocar perforation.
Trocar perforation of?
Venkatachala, sir.
Venkatachala, sir.
Of what?
Of what they are not mentioned.
Trocar from where?
Trivago perforation of small bowel.
Look again. It is the
hydrated decompression.
No, it's not hydrated. It is a plumber's point trocar into the stomach.
Port injury.
Okay.
So perforation of the stomach.
Palmer's point. That is the word is Palmer's. I don't know why that just happened.
Perforation of stomach. Trocar perforation of stomach. RI.
RI.
Yeah. So we now must show you how we deal with this. Okay. And the important thing to note is don't remove the trocar. Keep it there. Get ready for how you're going to tackle it. And see, that is a trocar. It is still there. We are ready with our sutures. And when we are ready for the sutures, you take out the trocar and immediately do the repair so that you minimize the spillage. Don't pull out the tube when you're pulled into bowel. Okay. Right. Let's move to the next question. All too common. What has happened? Again, laparoscopy going on. I'll play that again. Please type your answers. Type your answers.
Inferior epigastric artery.
Inferior epigastric, what happened?
Injury.
Okay. Yes, that is the correct answer.
Dr. Akshaya Purani.
Inferior epigastric blood vessel injury by trocar. How would you control it? This is what all we did to get control. We tried to compress it. We tried to burn it. Wouldn't stop. So finally we had to drop in sutures and pull it up and get a knot tied outside, and then looped it over so as to get compression on the vessel, and that finally stopped the bleeding. So that is an important way to knock it. And I think we have come to the last one.
So 1 second, who gets the point for this question, sir?
Whoever's typed, man, not the oral answers. Whoever's typed.
Anjali, I think she was the one with full correct this one.
Yeah, give it to her. The ones who are speaking orally are lazy people. They're not typing. All right. The last question. I think I'm well in time.
Sorry, Nishant, I think Akshaya Purani.
Yeah.
Akshaya Purani.
You sorted it, guys?
Yes, sir. Done.
Yeah, okay. Thank you so much. Yeah, here's this. What has happened? Showing that again.
Open fracture.
Open fracture. Next. Anybody else? That's not it.
Flexor retinaculum injury.
Avulsion at wrist joint.
Avulsion at wrist joint.
Both bone fracture.
Both bone fracture. All close by, but not. I'll give you one hint. The distal fingers are nice and pink. Do you think that'll be all right?
Both bone disarticulation. Open joint dislocation.
Well, I think I will give myself the 20 points because nobody has got this right.
Makeup is an answer.
Sorry?
Makeup.
Who said that makeup answer?
I think Anjali.
Yeah, I give it to her because she gets 20 points. This is a classical butter and jam reconstruction of a wrist injury for a movie. Okay, there you are. That is it. So that's a butter and jam to create a wound for a movie. So there we are. We've come to the end of this open quiz. I hope you guys enjoyed it. Scorers, can you tabulate and tell me who's got maximum points and the second one with maximum points? Others, is this quiz been entertaining, interesting? Some feedback, please.
It's a mind-blowing, sir.
Mind-blowing.
Get everyone hooked up, sir, on the tips of their toes.
Yeah, I've had 99 responses in the chat box, so that's good. A lot of people have participated. I just kept this brief so that it will finish in half an hour, and we have been lucky we finished in half an hour.
Arvind sir is saying very interesting. Another one more comment. All of them are saying very interesting.
Sir, I have the results.
Yeah.
The runner-up position goes to Dr. Anjali AB with the score of 30.
Yeah.
And the winner is Dr. Akshaya Purani with a score of 40.
Oh, lovely. Dr. Akshaya, Dr. Other doctor, very much. I clap hands and salute you. You've beaten the stalwarts of the society. The president and the chairman also have been beaten. So I appreciate your interest. Kindly hand over or inform the organizers or Glenn of your Google Pay account or your telephone number, and the money will be transferred to you. It is 1,500 rupees for the first prize and 1,000 rupees for the second prize.
Yeah, Glenn, please make it a note.
Yeah. And while the tabulating, since we've got a minute more, this is not part of the quiz. This is what invention is credited to Gabriel Fallopio. It's the condom. Okay, he's the fellow who discovered the condom. There's one more question. Whom do we have here? The best combination of brains and beauty. Name her, please. Hello? Anybody?
Devi Karani?
Devi Karani? No. Recent, man.
The WHO president, sir.
What's her name?
Swaminathan, I think.
Swaminathan. Yes.
WHO ladies, leader.
Leader. Not
WHO
chairman.
chairman.
Sure. Come on, we should know this, man. She is the clinical scientist and pediatrician, worked for tuberculosis, and right now she is the chief scientist at the WHO. So she is in the middle of all this COVID storm. So the extra questions I'm going, because I've got 1 minute more. Can you tell me who are her parents? She's from which medical college, and what does her husband do? Who is the father of the Green Revolution in India?
Swaminathan.
Ah, yes. She is a daughter of the Green Revolution, MS Swaminathan. And her mother is an educationist called Meena Swaminathan. She's an alumnus of AFMC and MD Pediatrics from AIMS. And her husband, Ajit Yadav, is an orthopedic surgeon. Yeah, with that, I have finished my share and well in time. Dr. Harisha, please take over and hand over to Dr. Gurshantappa to share the answers of the first round quiz. Dr. Lakshman, how many people have submitted?
Disappointing. I think the technology beat them.
Okay.
We have had only 13 people submitting. I, in fact, gave them 2 more minutes, beyond the 15 minutes.
Okay.
And also, I don't think they realized that there is a negative marking.
Oh.
So even though the scoring is on,
we did mention loss of wicket, right?
Everything was clearly mentioned, but somehow they have not appreciated it, because I do believe that our students don't read the instructions. However clear and succinct they are, they just don't read our instructions. It's been my experience. Anyway, I am now tabulating to see. I will talk to you. Let Dr. Gurshantappa. I need another 15 minutes to give you.
Yeah, please take it. Yeah.
Thank you.
Over to Dr. Gurshantappa, please.
Yeah,
sir,
thank
I'm
you,
going
sir.
to stop sharing my screen.
Yeah.
Yeah, you can take over, sir.
1 second. I'll just share my screen, sir. Sir, my screen is visible?
Not yet. Yes, sir. Yeah.
Yeah, at the outset, I thank KSCASI and Bangalore Surgical Society for having given this opportunity to all of us, the team, for the surgical quiz at this moment. I thank everyone. I thank Dr. Arvind Patel, our chairman, and secretary, Dr. Chandrasekhar, and the scientific committee chairman, Dr. Lakshman, and also Bangalore Surgical Society chairman, for having given this opportunity. I'll just go through the answers, which the quiz was conducted just now for prelims. The first question was, which of the following statement is not true about the hernia, about the lumbar hernia? The answer would be Hauschip-Romberg sign is positive in lumbar hernia. This sign is seen in obturator hernia. It is a pain radiating down from the groin along the medial side of the thigh in case of obturator.
So your slides are not moving, sir.
It's now, sir?
No,
sir.
We have to go to the
full screen. Make it full screen, sir.
Done, sir. It is full screen only.
No, it's still on utility mode. It's not on full screen, sir.
Maybe must have hung up.
No, it is full screen only here. What I'm seeing, sir.
Now it is better. A newborn baby, correct? Is it?
Yeah.
But it's not full screen.
Select the option of slideshow, sir.
Yeah, fine. Is it seen now?
It's okay, sir. Please continue.
No, it's
Yeah.
not.
Second question, newborn baby diagnosed with an umbilical hernia, what is the ideal time? It's 5 years. At the age of 5 years, surgical intervention may be the ideal one. Third one, the nerve most commonly injured in a laparoscopic preperitoneal inguinal hernia repair is B answer, that is genitofemoral nerve. Sir, is it seen well now?
No, sir.
Slides are not moving, sir. You can stop and restart sharing again.
It is seen, sir, now?
Yes, sir, it's
It is
visible.
Spigelian belt, but it is not full screen it.
Now?
It's still loading, sir.
Sir, Rajan, sir, you also have got the answer slide, sir. If it is not coming from here without wasting time. Sir, Rajan, sir?
You want me
Nishant,
to project?
Is it seen? Is it seen, Rajan? Nishant, sorry.
Sir, it's stuck on that slide where the Spigelian is, but it's not moving.
So,
Sir, Rajan, sir, can you help me out? If you can, you have the slides.
I have your slides, but Nishant, can you try? You've got it there?
I don't have the slides, sir. If you send it across, I'll do it in about 30 seconds. As soon as you send it.
Okay, wait. I'll try. I'll just come off the cell.
Because I'm able to see the full screen slides in my system.
And now it is moving, sir. Now it's moving, but not the full screen. I think you can proceed with this screen only. So we can able to see the answers.
Now it's seen now?
First over, fifth ball. The same thing.
Yeah.
Next slide, sir. You move the next slide. Not able. You're not able
See
to
now?
see. No, sir. It's not moving, sir.
Yeah, here I'm able to see the next slide.
Yes, sir. I think there is a lag, sir. Probably something to do with the internet connection.
Okay.
Here it is changing off after almost about 10 or 15 seconds.
Okay. Now I'm able to see the first over sixth ball. That is 1.6.
No, sir. It is in fifth ball only.
Okay, sir. Rajan, sir.
I'm getting it, sir. I'm trying to get yours out here.
Please, sir. Please, sir. You can start with the answer slide, sir.
Yeah, I'm just getting it. Yes.
Welcome, Dr. Chandrasekhar, sir.
Thank you. Thank you.
There's some hold up here also.
These slides are seen well without
yes, sir.
Full screen.
Now we can see the
sixth ball.
Sixth ball. Yes,
yeah. Okay. Now it is seen. Next slide is seen.
Yes, sir. Yes, sir. Now it is moving, sir.
Okay. Yeah, I'll present in this mode only. It's the full screen. What is the medial boundary of this hernia? It's a superior lumbar hernia. The answer is quadratus lumborum, the medial boundary. Lateral boundary will be the internal oblique, and the superiorly it is by the 12th ring. The 28-year male undergone Lichtenstein repair in the right inguinal, comes with a discharging sinus after 8 months. What is this SSI called? It's a deep incisional surgical site infection. What is this device? This was shown. This is hernia patch for umbilical hernia repair. That is a composite mesh, type of composite mesh. 70-year male known for chronic obstructive pulmonary disease evaluated by CT scan. What is the diagnosis in this? It is a apical lung herniation. You can see in the apex, that is through the Simpson's fascia.
Hello.
These two personalities are associated with which clinical diagnosis of what hernia? That is John Hoship and Romberg. That is obturator hernia. The sign what I have described in the previous question. The 65 years female underwent pelvic evisceration for pelvic malignancy 5 years back, presented with now the features of acute abdomen. What is the diagnosis? That is parastomal hernia. You can see there is a stoma around which there is a herniation. Staples may be safely placed during laparoscopic hernia repair in each of the following structures except. So it is the tissues inferior to lateral iliopubic tract. We are not supposed to put staples. What is this diagram depicts? It is component separation technique for ventral hernia repairs. All of the following are true with Spigelian hernia except what we feel that Spigelian hernia usually presents with obstruction, but commonly they doesn't contain any viscera. It is only the fat or the extraperitoneal fat. So answer is B, commonly contains viscera and known for less complications. The fourth, 68 years male got operated for intestinal obstruction. 3 years earlier to this, he was operated for irreducible inguinal hernia by mesh plasty. What is the diagnosis? It is because of the ischemia, the person has developed the stricture here. They are called ischemic strictures or Gary's stricture. 64 years male was evaluated for discomfort in the right lower chest while coughing with blunt in the past, having had a blunt injury to the chest. You can see in the picture that there is a herniation of the liver through the intercostal space. That is an intercostal liver herniation. What is this diagram depicts? It is Laplace-Isra for tensile strength of a mesh. Male presented for umbilical swelling. What is the finding and what primary disease he has? It's a typical, he has got a AV fistula in the left arm for dialysis, case of CRF with ascites and umbilical hernia. If the following investigation is done for ventral hernias, what is the intention of all these markings? It is a Tanaka method of calculating loss of domain in ventral hernias. 45 years male underwent upper GI scopy for dyspeptic symptoms. What is the diagnosis? You can see that J maneuver and there is an opening in the fundus. That is a hiatus hernia, paraesophageal hernia. If the following patient diagnosed to have a hernia and got operated, what is the hernia she has? You can see that abdomen, absolutely there are no swelling obviously seen. It is a Spigelian hernia. What are these types of photographs? That is, they are types of parastomal hernias. That is subcutaneous, interstitial, parastomal, and intrastomal types of parastomal hernias. If an obese person who has undergone surgery for obesity, what is this foramina through which herniation occurs is called? That is called Peterson defect and Peterson hernias, internal hernias. Name the procedure for ventral hernias where the mesh is not being used. That is called Ramirez technique. It is the anterior and the posterior component separation and the repair of the defect with primary tissues. An antenatal MRI for USG detected fetal anomaly. What is the full diagnosis? You can see the antenatal, the MRI here, the fetal skull down with the absence of occipital bone and the vertebrae with diaphragmatic herniation. The iniencephaly is called absence of occipital bone and the vertebral column in a fetus with diaphragmatic hernia. 9 months female child presented to emergency room with breathlessness and wheeze. Examination found to have tachycardia and tachypnea with retraction of ribs. So what is the diagnosis? You can see in the lateral form there are fluid levels. It is an anterior diaphragmatic hernia on the right side. What is the diagnosis with all these diagrams? You can see with the first photograph on either side there are swellings in the para midline area, that is bilateral Spigelian hernias. In a leg, what the patient was evaluated for a painful swelling in the leg while walking. What is the diagnosis? In a supine position, that swelling is not there. In standing position, it is there. That is tibialis anterior herniation. These all the questions are pertaining to hernia. 28 male got operated for a left groin swelling. Details are given below. You can see the photographs there. No family members have similar disease and is married since 3 years with no issues. What is the diagnosis? It is a non-familial male hermaphrodite uterine hernia syndrome. You can see the full whole of the uterus with fallopian tubes and the ovaries in a male. So these are the questions, and all the questions are targeted on hernia. And these are the prelims questions. And again, once again, I thank the organizing team and my colleagues for preparation of the quiz. Thank you all.
Thank you, Dr. Gurshantappa. That was a very, very nice coverage of the topic of hernia and the number of questions we can get from just the topic of hernia. I don't know if the students have noted, but the word hernia comes from the letter H, and H is the theme for this quiz today. And so you will find out in the next round. I've given a big clue that almost all the questions will relate to something that is connected with the letter H. Dr. Lakshman, can you give us the winners? Stop sharing, Dr.
Yeah, I stopped.
I'll need another 5-10 minutes because I've had to check the number of wrong answers manually. Okay.
Then
so,
Dr.
give me another 10 minutes, please.
So shall we start?
Lakshman sir, it is a 4 teams, sir. Lakshman sir, it is a 4 team, not 6 teams.
Yeah, 4 teams.
Yeah, 4 teams.
Yes,
but I need to, I can tell you that a lot of
take
people.
Your time.
Yeah.
Don't worry.
Yeah.
We will go on to the clinical case discussion and come back.
I will.
10 minutes to 7.
Yeah.
Yes,
okay.
sir. In the midway of the clinical discussion, we'll give a break and announce the.
Yeah, sure.
Yes. So now, thank you, sir. Thank you, Gurshantappa, sir.
Thank you.
Yeah, we'll move on to the next session, that is case presentation. by Dr. Yousuf from KIMS Hubli. Dr. Yousuf, you are there?
Yes, yes, sir, I'm there, sir. Can you hear me, sir?
Yeah. So, Sharat, share the slide, please. So again, our faculties, Dr. Santosh Jana Brahm, sir, Dr. Prashant sir, and our moderators, CS Rajan, sir. Yeah, proceed with the presentation.
Can I start, sir?
Yeah, please.
Myself, Dr. Good evening to everyone. He is 31-year male, resident of Haveri, a labor by an occupation. He came with a complaint of pain abdomen since 1 month and mass per abdomen since 1 month. Coming to the presenting illness, patient was apparently normal 1 month back when he had developed the pain in abdomen with moreover in lower abdomen, insidious in onset, non-progressive, dull leaking type of pain, intermittent in nature, non-radiative and no aggravative or relieving factors. Following the pain, the patient had noticed a mass in the lower abdomen, which is non-progressive. There is no history of vomiting, there is no history of altered bowel habits, there is no history of fever, there is no history of burning mutation or hematuria. Coming to the past history, patient is not a known case of hypertension, diabetes mellitus or tuberculosis, and there is no history of previous surgeries. And there is nothing significant in their family history. His personal history is a non-vegetarian by diet and has a good appetite with undisturbed sleep and a regular bowel and bladder habit, and the tobacco chewer of since 15 years. The marital history, he has a marriage life of 3 years with the no issues. And the patient also mentioned that he doesn't have a both the testes in the scrotum. Coming to the general physical examination. Coming to general physical examination, here is a 31-year male moderately built and nourished by the pulse rate of 80 beats per minute in right radial artery and BP of 110/70 in the right brachial artery with a respiratory rate of 16 cycles per minute and afebrile by nature. And height of 1.48 centimeter and weight 60 kg with a BMI of 27.39 and ECG scoring of 0 with no pallor and generalized lymphadenopathy. Coming to the perabdominal examination, on inspection, there is a mass of size approximately 12 into 10 centimeter seen in the suprapubic region extending up to the umbilicus superiorly and mid-clavicular line on either side, and the lower border is ill-defined with a smooth surface. On the leg raising test, their mass become less prominent. The corresponding quadrants move equally with the respiration, and the umbilicus is central with the hernias orifices intact. Scrotum is underdeveloped and testis is not seen in the scrotum. The next slide is about images. You can shift over. Yeah. Coming to the palpation, the abdomen is soft and non-tender with a solitary mass of size 12 cross 10 centimeter present in the suprapubic region, extending up to the umbilicus superiorly. An inferior border couldn't be made out, and the fingers cannot be instrumented between the mouth and the pubic symphysis. On either side, extending up to the mid-clavicular line, smooth in surface, horizontally mobile with the restricted vertical mobility and the firm in consistency. There is no organomegaly and there is no other palpable mass in the abdomen. External genitalia, scrotal sac appears empty and the bilateral test is not palpable. You can see there is a horizontal mobile but restricted vertical mobility. Next slide, please. Question. Dull note heard over the mass with the rest of the abdomen is resident. On auscultation, bowel sounds are present. For rectal examination, the fecal staining with a normal mucosa. Cardiovascular system examination and respiratory system examination is normal, and there are no palpable supraclavicular lymph nodes. Summarizing the history and the clinical examination finding: 31-year gentleman presented with the pain and mass in the lower abdomen since 1 month. On examination, mass of size 12 cross 10 centimeter present in the suprapubic region, extending superiorly up to umbilicus, on either side up to mid-clavicular line. Inferior border couldn't be made out, with a smooth surface, horizontally mobile, with bilateral testis not palpable. With all this, I'll put my diagnosis first.
Dr. Sharath, did you mention secondary sexual characteristics? Well developed, not developed? Secondary sexual characteristics.
No, sorry, sir, I have not mentioned it. It's well developed, sir, actually.
Yeah, you should mention it.
Okay, sir.
And if you notice, this patient has got a very sparse hair. If it's a male, the skin is hardly you can see any hair on the body.
Yes.
Maybe some gynecomastia also?
No, no gynecomastia was there.
Okay.
So,
yeah. So anything to say about the history, Santosh sir?
Any urinary symptoms?
No urinary
particularly?
No urinary symptoms.
Nothing in the urinary symptoms. Okay, fine. As rightly mentioned, secondary sexual characters have been mentioned. Okay. It's fine. Do you think that the mass is horizontally mobile, or is just the mass being big gives an impression that it is a mobile one?
Because the mass is big, so it gives an impression of.
Yes, it's not really a true mobility. It's just the fact that it is a big mass which gives rise to. In regular examination, you cannot find this mass either.
No.
Good. And hernial orifices are normal.
Intact.
So it's generally a asymptomatic swelling with hardly any symptoms, just a pain, just about a pain, dull aching, and a mass abdomen. How do you proceed with your thinking process?
So the clinching point is that he gives the history of bilateral absent testes, sir. And on examination also the testes are not palpable.
So
keeping that in mind, I may think of about a testicular tumor, sir, most probably, because of a young age group with the 1 month of history and bilateral test is not palpable.
So would you say right testis or left testis?
Yeah, what is the point against it being a testicular tumor?
The only point against one is in the midline swelling, lower midline swelling, sir.
It's a solitary midline swelling with no laterality. Okay.
So is that in favor of testicular tumor? It's a midline swelling.
It's an unfavorable point.
Okay, it's a midline swelling.
Yeah.
So what other things have to be considered apart from
so being one more point favoring patient because of mobility, I may also think of
connection seems to be little.
Hello, we've lost you.
Small bowel gist, sir. But again, can you hear me, sir?
No.
Yeah.
Small bowel gist. Now it is. Anything else that you can think of? Midline swelling, fairly
Absent testis. Disappearing testis, rather.
Lymph nodal mass, sir.
Is it a position to have a lymph nodes there? Logically?
No, sir.
No.
Also, when you say it's uniformly smooth, having
Yes.
lymph node would be difficult.
Yeah, it is not in the region of lymph nodes. What else is there as a primary organ?
Like a uterine female.
Bladder. And is this a male patient clinically?
Female, it's like ovarian.
Yeah, you have, since the secondary sexual characters, as rightly been mentioned, with hardly any sparse hair, you don't know whether it's a phenotypically a male or a female. So a possibility of ambiguous genitalia or something of that kind with the uterine mass.
Uterine swelling, yes.
Yeah, uterine has to be concerned. Now, assuming that it is a male patient, can you think of anything else? You need to keep a wide thinking process here. Can it be a mass rising from bladder?
Yes, sir.
Okay. Can it be a mass rising posterior to the bladder?
Retroperitoneal.
Yes. Can it be something like a chordoma which is coming up?
Could be, sir.
Presacral tumors. So you have a set of tumors which are pre-bladder, second is bladder, third is beyond the bladder on the retroperitoneum. Presacral, teratomas, chordomas, all those kind of, because it's a midline swelling.
Midline swelling.
Organ of Zucker candle. Arising from organ of Zucker candle.
Possibility is there, sir.
Yeah. Now, having got
one cyst of Urachus also you can think of, which is developmental.
Yeah, that's bladder related. We'll come to that in a little bit. Bladder related things, pre-sacral, I mean, anatomically. Is there anything which can, as a developmental anomaly, since there is a absent testis on both sides, can you think of something which is genetically, I mean, congenitally happening? Rare possibilities again. You need to keep everything together. Can it be a fused kidney midline undescended? Again, asymptomatic.
Yes.
Again,
yes, sir.
so, yeah. So these congenital anomalies have to be kept in mind. Gist and all would come as probably by exclusion. I don't think one should clinically entertain gist of a small bowel, because by order, gist of a small bowel is not. This is not the position, and probably that is not. Other examiners, please, in the thought process.
The importance is the absence of the testes and the doubt on the sex, genotypic and phenotypic sex of this particular individual. Always go for the lesions that can arise when there is intersex kind of issues. And if it was a female, this is almost typically like a fibroid uterus or an enlarged uterus. So you may have to think of in those lines as being the primary diagnosis. Midline structures, when it is in the midline, think midline. Bladder, behind the bladder comes some this thing, embryonic rest that can give you this kind of tumor. And chordomas, they can come out of the presacral area and present in the hypogastric regions. So with these in mind, we would now like to know how you would like to evaluate this patient. What would you do?
Chordoma will generally be fixed. So anything mobile is uterus, ovary, or bladder. So we have to look into that.
Thank you.
Yeah, that's exactly the reason why initially itself a very big mass, which gives an illusion that it is a mobile one. Anyway, it's not a point to be debated. Presacral. Yeah.
Can we have his colorectal findings?
He said
it's normal.
Yeah, he said normal. Okay, now we are pretty sure that it is in the pelvis, but it is outside the pelvis. Correct examination is not able to find the lower limit. It's something which is probably a little above than you're palpating. How do you go about investigating this patient?
Yeah, the first part I'll do an ultrasound abdomen, sir, because in lower midline.
Would you like to have an X-ray done on this patient straight away? If it's something like a dermoid, something like almost a lot of things can be found out just on X-ray.
Plain abdomen.
It's not a bad investigation to be discarded with the contempt. So particularly in congenital disease, congenital things, a lot of information can come from just a simple. Right. Then I agree that you would go for a ultrasound. Okay. What all things will you be looking at the ultrasound?
One is the origin, sir. First, the site of origin, mass origin, solid or stick, the thing.
Or variegated echo.
Variegated appearance, yeah. Keeping in mind and
what else?
Also if any lymph nodes enlarged.
Okay.
Probably you may get to know. One about the bladder. We'll get to know.
Yes. Then see whether both the testes are could be visualized or not, because it's absent in any case. And we should look at the renal tree. By the months, whether the kidneys have come down or kidneys are obstructed on either side, because it's a massive. Yeah, so all those things can come in and you add the vascularity by doing a Doppler. Okay, so these are the things that you are going to look for in an ultrasound. And obviously, you would also rule out the possibility of intra-abdominal fluid collection and other, in case there are other masses, skip lesions or metastasis in the liver, etc., etc. Okay. So have you got an ultrasound done? Heterogeneous mass lesion, yeah. Pelvis, bladder, anterior to this, superior to the bladder. anterior to scrotum.
With few calcium acquiring neoplastic.
Okay. Anyway, it's a intra-pelvic tumor with foci of calcification. Would that ring any bell to you, foci of calcification?
Calcification, heterogeneous mass could be.
What's the difference between homogeneous and heterogeneous?
Homogeneous is smooth, sir, single mass. Heterogeneous will be like the multiple.
Homogeneous, the characteristics are uniform. Heterogeneous, the characteristics are varied.
Varying, sir.
Okay.
You may have an isoechoic, you may have a hypoechoic,
Hypoechoic, sir, or a
hyperechoic area. So it may have fluid content, it may have cellular component.
Cystic or solid content.
Yes, so that's what it means with foci of calcification. They have not actually mentioned about the character of the calcification, but calcification. Okay, fine. What next would be your investigation?
So will you still think of testis at this juncture?
Sir. Pardon, sir?
Testis. Testicular
Testicular origin. Do you still think of testicular?
Could be, sir, because still this test is not visualized, sir. So
the testicular origin tumor should not be mobile. That is the only.
Yes, that's on the against point.
And it is intra-abdominal superior to bladder. So unlikely.
Unlikely, very unlikely. Very unlikely. Because if you trace as, I think it's Dr. Srivatsa who has been talking.
Yes, sir, that's Dr. Srivatsa.
Distinctly, if you trace the descent of the testis, the chance of a supravesical mass is very unlikely. Right? So, and at this stage, would you like to do any further imaging or go for some?
We'll go with the CT abdomen and pelvis, sir.
Okay, fine, great.
Agree.
Want to know about the mass origin and want to know about the lymph nodal status also, sir, if present.
Right. They have given you a very open report: lobulated mass, peritoneal cavity, superior to bladder, closer to small valve. We knew all this on clinical examination. It's not offered.
As well as in ultrasound, as well as in ultrasound. Do you have cuts? Do you have any other cuts to show?
Sorry, it's deck.
No. Okay. Have they mentioned anything specific about bladder at this stage? Is it?
No, sir. No, it was normal. They didn't mention anything.
No. Whether they had said normal bladder or an abnormal bladder or
no, sir. Normal bladder.
Normal bladder. Because I can't see any lower down. I can't see any cuts. So I trust you that normal bladder. Normal bladder. Okay. What further? Any reference to the kidney functions and renograms?
Like
no compression of the
no compression on the any IV, sir. No, not vessels.
Okay, fine.
Which again came to the point that in clinical examination you must mention that there's no pedal edema on both sides. Whenever you have midline masses, it's a useful point to mention, and also mention the pulsations are normal in both the lower limbs.
Compression upon IVC, sir.
Yeah, IVC aorta. One of the points, especially umbilical masses in the midline, you must mention that. Yeah. So what next now? What do you want to do? We are all in a quandary.
At this level, what else would be your investigations?
Yes.
Still, because still we didn't find the so and the testes are not in both of the imaging. We could, no.
Yeah. What any other investigations would you like to do at this stage?
We could go even with the any tumor marker.
Yes. So we can do alpha fetoprotein. We can do an LDH. We can do a beta HCG. Okay. So is there anything done? Okay.
Yes, sir. In alpha fetoprotein was elevated and LDH was elevated.
Well, you're pushing us towards something anyway. Why can't this be an ovarian malignancy, man?
Male patients are first.
Was the CT showing any uterus? Because you didn't show so many images, only one image, 4 images were shown. You are trying to take exams for us. Was there any other finding like other than like a uterus or a rudimentary uterus or something seen in this?
No, sir.
Okay.
Okay.
What do you think from this elevated marker? Alpha fetoprotein is high.
Be like in testicular tumors also. In
What form of testicular
kind of
tumor?
testicular tumor?
Germ cell tumor.
Non-germ cell tumors.
These are non-seminomatous germ cell tumors. Sir.
Non-seminomatous tumors.
So what form of non-seminomatous germ cell tumor can it be?
Embryonal or like yolk sac tumors.
Yes, these are the 2 tumors where AFP can be raised.
Yes,
Okay. So what next? So with the progressional diagnosis of like this, what is your next movement?
Next, I have like we'll proceed with the
Proceed with what?
surgery, sir.
Pardon?
With
Refer gynae.
laparoscopy with the excision of a tumor and right
No,
on.
Do you think that there was a chest metastasis, lung metastasis?
You haven't
mediastinal metastasis?
Chest X-ray was not.
Chest X-ray is not good enough. No, okay. Now let's see that. What are you looking in the chest X-ray?
Like we should look over cannonball metastasis. Like look.
Mediastinal nodes also can be there.
Mediastinal nodes.
Mediastinal
Anything
virus.
else? Anything else?
Fusion.
Where? Pleural effusion? Pleural effusion. You could also get pericardial effusion. Pericardial effusion. Okay. So a cardiomegaly can also, the pericardial fluid can, that also can be suspicious. Okay. So has it been done? Chest X-ray being done?
Chest X-ray.
It's been done, but it's normal. I have not.
Even a CT of the chest would be a recommended investigation at this level. Because
in fact, a CT chest would be better than a chest X-ray.
Exactly. But then I just wanted, since he said
sure.
about CT, what I mean, chest X-ray, what do you plan to do? A CT test is mandatory in this case. Well known, even in a testicular tumor, it's well known to skip the retroperitoneum and have metastasis in the lungs and in the mediastinum. So it's possible. Okay, fine. Metastatic workup was negative.
I was negative.
Okay, fine. Good. So what next?
Next, we have proceeded with the surgery, sir.
Fine.
We have done like explorative laparotomy with the excision of left testicular tumor and the right appendectomy, sir. This was the findings. There are the two, the huge mass, or it's an you can see that huge mass left testis.
You must put a scale next to such pictures, please. You can huge. I can put a small one and blow it up. You must have a scale or an instrument alongside these pictures to give us an idea of the size. Okay. Yeah.
A plastic scale with the area dry. You have to dry the specimen first and then take the photograph.
Okay, sir.
Any cut section?
No, like I put on the intra photos.
Okay. What happened to the other testis?
This is the right testis, the small one, and the left testis. Sir.
Okay. Both are.
Yes, sir. HPI report has came as a left mixed germ cell tumor of the left testis and the nodal cell hyperplasia of the right testis. Sir.
Okay. But where was this lesion exactly located, being giving impression of midline?
Lower midline, just at the suprapubic region, sir.
Retroperitoneal or intraperitoneal?
How do you decide this is right testis and that is the left testis, which is atrophic? Because both are in the midline.
Yes, so we got in like. the huge tumor was
Both are
improper.
not in the line of path of testicular descent.
Yes, sir.
So it's in the midline. How did you decide this is right testis, that is left testis, and this is atrophic and it's arising from the right testis?
By tracing the cord structures.
If the undescended testis, where is the cord?
Yes.
It is above the testis.
Yes.
The testis is never in the scrotum.
Correct. Side like
You should have traced these the testicular vessels also and taken them. So that would have shown which is right and which is left.
Because you have to relate it to an anatomical structure to say this is right, this is left. To something related to the testis where it's along the path.
Yes, sir.
Venkatachal.
Sir?
Yeah.
Yes, sir.
The small one, it was on table lying on the area of the right deep inguinal ring.
Right, sir.
Yeah, that was a testis on the right deep inguinal ring area. So hence that was labeled as right testis. The remaining was whole of the mass, like it was in the pre-sacral area, like what Dr. Santosh sir was mentioning. It was the peritoneum was covering over the mass and it was abutting the liver, bladder anteriorly without infiltration.
That's why it was giving some mobility.
Exactly. It was a huge tumor in the retroperitoneum, giving a treetop mobility at the summit of the lesion because of its size, mere size.
Correct.
So because the normal testis was at the deep inguinal ring, that was labeled as a right testis.
Okay.
In the specimen. In the specimen.
Right, sir. Right, sir.
So the final pathology has come out as mixed germ cell tumor. Okay, fine. And retroperitoneum, there were no obvious lymph nodes.
No lymph nodes.
No lymph nodes.
No lymph nodes.
Okay, fine. So what do you plan to do now?
Is there a role for PET-CT scan even now? Is there a role now that you know it is a malignancy? Is there a role for PET-CT scan even now?
Not a metastatic. There is no.
There is, because you don't know the exact stage, because you have to treat this disease now. Better to have some form of scan which extends to the thorax also even now.
CT chest was done. In fact, I think he has not mentioned in the presentation. CT chest was normal. CT chest was normal. There was no metastatic disease in the chest.
What next now? Now that you have done the surgery, what would you like to do? What is the T stage in this mixed germ cell tumor? All it is retroperitoneal tumor, so we have to think it different now, not like a scrotal tumor.
It was like a T1 stage, sir. With N0 and M0, sir.
Remove the lymph nodes. Have you taken retroperitoneal nodes?
That's what I asked.
The abdomen.
There was no lymph node.
So only when you remove, you would have got to know the nodal stage. So what would you like to do now, next?
With the
That's where this patient would have got benefited from a PET-CT scan, because if there are any uptake in the lymph nodes.
Non-seminamitous germ cell tumor.
So what would you like to do next now? Any role for chemotherapy?
Connectivity is poor.
Any role for chemotherapy? I think this patient would get benefited with 3 cycles of BEP chemotherapy, because it is retroperitoneum. Even though it is reported as T1, we don't know the lymph node status. When you are in ambiguity, young patient.
Yousuf, you are muted. You can unmute yourself.
Yes, thanks.
So, yeah. medical oncology consultation with an appropriate chemotherapy would be a good choice, a good option. Anything else they should be worried about on this patient?
Sir, one more thing, sir. Santosh, sir. Now that orchidectomy is done at around 2 or 3 weeks, we better repeat the markers.
Yes, sir. We have to repeat the
Just
marker.
Because post-orchidectomy markers are more reliable than the pre-orchidectomy markers. That is used for staging.
Yeah, I was coming to that. One is what next would be after a reasonable period of time. It's not necessary that you in the next post-op day you do this, repeat this thing. Anything else that would bother you at the age of 31?
Fertility.
Fertility is possibly would have been a question mark even if he had developed no tumor, because both the testes were housed well inside the abdomen. But whatever little function that he had on the testosterone side would be going. So one should seriously look at, symptoms of testicular failure in him also, though other sources of testosterone are there. But then whatever little this thing would be looked at.
Yes.
Okay. Now imagine that this particular patient had just for continuing, how many more minutes do we have?
Another 10 minutes, sir. Another 10 minutes we can discuss.
Let's imagine that this particular tumor was, can we discuss or got?
Yeah, please, sir, please. We can discuss, sir, till anyway, the final speech starts at 7 o'clock. So
Okay.
before that.
Harish, you need some time to announce the winners also.
Yes, sir. Anytime,
5 minutes
sir,
time for that.
No, before that, anytime Lakshman sir can announce the results of
No,
the final.
5 minutes, we'll continue this discussion.
Yes, yes.
Okay.
Please, sir.
Yeah, okay. Anybody can ask the questions. I'll answer later. I mean, ask the later on.
So the patient will need chemotherapy because the staging is done on the post-orchidectomy markers. Then you will stage the disease S0, S1, S2, and S3. So you will this level is not used. The post-orchidectomy marker level is used for staging. Then you will decide that if it is still the markers are elevated, means there is disease somewhere, microscopic disease or in the lymph nodes or in the lungs. So then you can treat the patient because you have not touched the lymph nodes and PET CT has not been done, no uptake in the, that PET CT is better than CT scan because you can at least see uptake in the lymph nodes. And the lymph nodes are that drain the testicular tumors will be at the root of the testicular artery. Okay, below on the left side, it is below the left renal vein and the pre-aortic, para-aortic and the intra-aortic caval nodes. And the lymph node dissection for testicular tumors is more than what we do for other malignancies like uterus, because you go up to the diaphragm. You have to go up to the diaphragm and take all the lymph nodes, and the common iliac lymph nodes also are taken. So once you have given the chemotherapy, then we will follow this patient on because BEP chemotherapy anyway, he will not cause much of a problem. He will tolerate it well, and also he will not. You have removed the both the testes and descended testes, so that he won't have any future. He cannot have any sperm banking or anything. Nothing is possible. So he has to adopt a kid. So or some other forms of artificial reproduction.
Venkat?
Yes, sir.
If the PET CT shows no evidence of metastasis elsewhere,
and the markers are normal.
Yeah, markers are still high.
Markers are normal. You have to follow the patient closely.
No, I'm not talking about markers being normal. I'm just looking at the role of retroperitoneal lymph node dissection. What would be the role?
When they have opened, either a frozen section would have confirmed, or based on your elevated markers, you could have done a retroperitoneal lymph node dissection at the same time. That would have been a much better option than just the orchidectomy. But now that is not done. You know that there are recommendations of 2 cycles of carboplatin area under the curve of 7. 2 cycles of carboplatin is in stage 1 non-small germ cell tumors is well accepted, well tolerated, and is a very good chemotherapy option also.
Yes, sir.
And then you can follow up the patient.
Yes.
Now the whole thing is, clinically, can you make a diagnosis of testicular tumor? That was what was bugging me, looking at the position, mobility.
Sir, I think since a patient has got bilateral undescended testes with a mass in the lower abdomen, that becomes a strong point thinking in terms of a testicular.
Midline.
That is a point against, but straight away it doesn't rule out the possibility of testicular.
Even, sir, the issue is even ovarian tumors, sometimes left ovarian tumor will be sitting on the right side.
Right
and
side.
This is sitting on a small, like pseudopedicle. It is sitting like a small mesentery in the retroperitoneum. So it has anyway fallen towards the midline because of the presence of sigmoid colon. This space was easy for it to.
Venkat, for student's sake, I have two clarifications pertaining to this case. You said that the staging is done with the tumor markers after architectomy.
Yes, sir.
Is that the case, or tumor markers values before architectomy when you diagnose the disease?
Markers are taken for staging.
For staging, okay. And even CT doesn't show any retroperitoneal nodes, and on table when the nodes come, if the histopathology comes as monomatous tumors like this, then in such a scenario, I think chemotherapy of 2 cycles is recommended without just observing the patient. Is it right if they put like this?
I think one need to. I think one need to do it even at this stage to to decide, not only to decide, also to kind of document.
Five to 7 days, sorry, 5 to 7 days it comes to normal off light. So by that time, 3 weeks around, it would have normalized if it was only tumor related. I think Harish can take over.
Yeah.
Thank you. Well done, man.
Yeah.
Thank you, sir.
Good.
Thank you, Dr. Santosh Jansan.
Thank you to all.
Dr. Guru Shantapa sir, Dr. Shival sir, and Dr. CS Rajan. Now I welcome Dr. CS Rajan to proceed with the final rounds of the Dr. K S Shekar State level quiz.
Dr. Harish, has Dr. Shekar logged in, please?
Yeah, I called him, sir. I messaged him also. I'm waiting for his response.
Okay.
Yeah.
Anyhow, we had a interesting quiz on hernia for the preliminaries. We are a little disappointed that the number of responses were very few. I don't know if it is due to technical issues or hello. Is somebody wanting to say something?
No, sir. Proceed, sir.
Yeah. Okay. So we don't know if it's technical issues or not, but we do appreciate the few people who did participate. It's somewhere around 13 or 14 people's answers came through within the time frame. And we have done the correction. These are the 4 teams that will be qualified for the finals. I hope they are present. Can you all put on your videos, please, so that we can see you all in the view? I'd like to see, and when we say so, we'd like the person to light up and put their hand up so that we know who it is. The 4 qualifying teams are Shreya Shamala from BMRCI.
Yes, sir.
Hi, and your partner's name is Shreya?
Atish B. Shetty, sir.
Oh, lovely. Congratulations. You're one of the team, and you are now being designated as Team 1. Understand?
Thank you, sir.
Yeah. Well done. And I hope you score well in the finals. Okay.
Thank you, sir.
Second team is from Kim Hubli, and they are Dr. Abhishek Chowdhury. Can I see Abhishek Chowdhury? Abhishek Chowdhury, are you around? Can anybody pick up Abhishek Chowdhury on the? Because if he's not there, then he won't be able to take part. Abhishek?
Nishant or Arish, please call them.
Abhishek? Dr. Gurshantappa, Hubli gentleman, do you know who that is? Abhishek?
Anyone from KIMS Hubli?
He is logged in, I can see, sir.
Ah.
Abhishek SS, is he the same person? Abhishek SS.
The other
Abhishek is
No,
from
he's
MNC.
connected. He's getting connected. I just called him. He's getting connected, please.
Yeah, so he's there,
Yeah.
no, sir?
Yeah, he is there. He's there. He's there. He's getting
Please
connected.
tell him to log in also and be connected. And when he connects, he is team 2, team number 2. The third is also from KIMS Hubli, Dr. Yousuf Khalil.
Yes, sir.
Yousuf, oh, you're the presenter. Yeah, I hope your testes are in the right placement. You'll do well, okay? Good. And your partner's name?
Abhishek CV, sir.
Sorry?
Abhishek CV.
No, Abhishek is one and Yousuf.
One more Abhishek.
Sir, there are two Abhisheks. One Abhishek CV and there is one more Abhishek SS. I don't know who has.
Abhishek Bachchan and non-Abhishek Bachchan, right? Okay. And your team 3, Yousuf, you
Yes,
and
sir.
your team. Incidentally, Yousuf, you presented.
Sir, Abhishek Chaudhary here, sir.
Where are you, Abhishek? Can you
Yes,
put
sir.
your hand up
Sir.
and shake? Okay, has our team people seen him?
Yes, sir.
On the video, Abhishek, on the video.
Yes, sir.
Get on,
Sir
yeah.
wants to
Switch
see
on the
me.
video, Abhishek. Yeah.
Yes, sir.
And we need the video on for the entire quiz, okay? Because we can't
sir.
have blank. We have to have all 4 of you on quiz. Abhishek?
Yes, sir. Starting video, sir.
Okay. You are team number 2, okay? Team 2.
Yes, sir.
Team 3 is Yousuf. Dr. Yousuf, your
Yes,
team
sir.
2. And the last is Tanvi Kumar, BMCRI. Dr. Tanvi.
Yes, sir.
Hello, ladies also doing well. Yeah, upcome. Keep it up. Ladies cricket is very good today. Very much more paying occupation than being a doctor. Anyway, so Dr. Tanvi, what's your partner's name?
Dr. Nivedita.
Nivedita. Tanvi and Nivedita, you are team number 4. Well, congratulations to all 4 of you. We really appreciate your effort and the level of scoring you have done. We have had slight modifications in the scoring system so that we could get it on a level plane. And these are the 4 toppers of that written quiz. We will now be starting the state level quiz final rounds, which is oral rounds. We are about 5 minutes ahead. Can we start, Dr. Harish, or do you
Yes,
wait till 10 o'clock?
we can start, sir. Dr. Shekar sir expressed his inability to log in. So he told that please proceed with the quiz.
Yeah, then please make sure that you get a recording and send it to him on a link or something, okay?
Definitely, sir. Definitely.
Sir, Abhishek Chaudhary here, sir.
Hi, Abhishek. Yeah. Yeah, Abhishek, you are team number 2. Okay.
Yes, sir.
What's your partner's name?
Navina GS, sir.
Oh, Navina. Right. Nice to see you guys. So do
Thank you.
well.
Thank you, sir.
Yeah. So Shreya and Shamla is team 1, Abhishek Chaudhary team 2, Yousuf Khalil team 3, and Tanvi Kumar team 4. We will not be referring you to by names. We will be calling you by teams.
Yes, sir.
Right. Now, this is a annual feature, and I have to say thank you to Dr. Shekar, Dr. C.R. Bilal, and Dr. K. Lakshman, who set this off all on a course of railway tracks and gave us a good push in the year 2000. So this is the 21st year of its running continuously. I have been associated with it for the last few years, and I've enjoyed doing it. I have to introduce my team. My team consists of Dr. Hoshni Mubarak Khan. Dr. Hoshni, can you raise your hand, please?
Hi, sir.
Hi, Hoshni, Dr. Nishant Lakshmikant,
Yes, sir.
who took you all through a very good class on instrument yesterday. Dr. Niranjan Paramachmaya.
Yes, sir.
Yes, he is also there. Dr. Sendil. Sendil, are you logged in?
Yes, I'm here, sir, but I think my name, it's mentioned as Nishant's name, but yeah, I'm here.
Okay. Nishant, can you change his name to Dr. Sendil, please? Sendil is all the way from Aberdeen in Scotland. and you can see that he is, in spite of it being so cold, he's very warm in his room over there in his scrubs.
Yes.
Senthil, you seem to have lost a lot of hair since I last saw you, man.
That's, yes, sir, what to do?
Don't
Also
compete
some
with
weight,
me,
I
man.
think.
Come on. And anyway, thanks a lot for having the interest and coming in from Scotland. And of
Privileged,
course,
sir.
we have Dr. Manish Joshi, who is the senior oncological and GI consultant in Bangalore, who's taken time to make an interesting round for you guys. Manish, where you? Blue shirted. Yeah, hi. Yeah, little boy blue, come blow your horn. Come on, very good. The quiz is exactly for 1 hour. It is timed so that we are going to go on time. The number of rounds are 5 rounds, and they will be direct questions and what we call as fastest finger questions. Fastest fingers are those which will need chat box answers, and that will be introduced to you by the host who is running that round for you. There are no negative markings, and generally it is 10 points for every correct answer. If the question is passed and is answered correctly, you get 5 points. The whole thing will finish in about 55 minutes, and then we will have a short closing ceremony and a thank you by Dr. Gurshantappa. Did you guys like the preliminary round? How did you find the preliminary round? The 4 teams can answer, please. Shreyas?
So it was a very analytical prelim, so it was really nice to diagnose and then further thing.
Dr. Tanvi, any comments on the prelims?
It was very good and innovative, sir, especially the question about component separation with the image and stuff.
Yeah. Yeah, you have to credit the quiz master for that, man. He's put a lot of effort into it. Dr. Yousuf, I know he's your boss, so you better say some nice things.
We never thought hernia take us to so far, sir.
Yeah, it's always when you don't know what it is like. And Dr. Abhishek Chowdhury?
They're all clinical and very practical questions, sir, that we encounter. The pictures are also.
It covers a wide range of your own theory knowledge that you have.
Yes, sir.
Okay.
And
so
all the pictures were real photographs of what the sir has done.
Because if we give you theory questions, you'll hit the net and get the answer in 5 minutes and the answer. No, so that's why we have to make our own questions. And if you guys saw the other round of quiz also, it's all innovative. It's all unique, not something that is easily Googleable. Right. Now we are ready and we are going to be starting. The 4 rounds, direct rounds will be first, and there's a 5th rapid fire round. I will request Dr. Hosni Mubarak Khan to take you through the first round, which is going to be his baby for the next 10 minutes. Scorers, the other team members of the quiz team, please do the scoring. And one of you, please keep a little bit on time so that he doesn't exceed his 10 minutes. Over to you, Dr. Hosni. You
Thank
can
you, sir.
share the screen.
Thank you.
Sorry, one little last word is that thanks immensely to Dr. Lakshman. He is our technical champion. He is the one who's been able to bring it up to this digital format. And I think we can all give him a round of applause for the amount of effort that he puts in. Thank you, Dr. Lakshman. I appreciate every word.
Thank you very much.
That you do. Yeah, thank you. Yes, Hoshni, please take one.
Sure, sir. Can you see the screen, sir?
Yeah, we can.
Okay. Hello and welcome you all to round 1 of Dr. K S Shekar KSCASI SQ 2021 finals. I am Dr. Hosni Mubarak Khan, Associate Professor from Ambedkar Medical College. At the outset, I would like to thank the Karnataka State Chapter, Surgical Society of Bangalore, and Dr. Rajan sir for giving me an opportunity to be a part of this prestigious quiz team. Also, at the outset, I would like to extend my thanks to Lakshman sir for all the technical support he has provided to project this quiz through an electronic platform. Congratulations to all the teams who have made it to the finals. The theme of this quiz is based on the letter H, so I will be doing a round on hemorrhoids. And to keep you all motivated for the upcoming rounds, this round is going to be quite simple and the most scoring round for you all. Okay. Now, said that, let us have a look at the scoring pattern. I will be having 4 direct questions. at 10 points each for each right answer in 10-second time frame. And if the question passes out to the next team and they get a right answer, it is going to be a 5-point within a 5-second time frame. 2 fastest finger questions where you are going to type your answers into the chat box only, and the team who gets the answer right first within a 30-second time frame will get a 10-pointer. Please note that there are no negative points for any of the above questions. Is that clear?
Yes, sir.
Okay. And be it any question, all the teams should be alert to any of the question directed to any of the teams. Okay. It can be a past question to you too. Okay. So that said, can we move on to the first question of round 1? All teams ready?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
So this question will be a fastest finger question, open to all the teams, and the answers to go into the chat box. So name the procedure being done. This is a 30-second video clip. Answers to go into the chat box. Can anyone please monitor the chat box?
Sclerotherapy.
You have a clue for diagnosis of the disease for which the procedure is being done in the PIP. Prashant, is it time up? 30 seconds was the time frame.
We'll have another 10 seconds. Time up, sir.
Time up.
Teams. The right answer was laser lateral internal sphincterotomy. Okay, this is a closed technique where the approach is medial to lateral. There are 2 techniques in the laser itself. One is open and closed, and here we have used a medial to lateral approach. The clue to your video was you had to closely have a look on the tip of the probe. The direction of it was pointing towards the internal sphincter. If it was a laser hemorrhoidoplasty, the tip would have been pointing towards the anal canal. Okay, so we have used a lasertronic device, which is a diode laser 1470 nanometer with a bare fiber, delivering an energy of 10 watt in a continuous mode. So none of the teams get a point for that. Now let's move on to the direct question. The next direct question will be to team 1. Team 1?
Yes, sir.
Yes, sir.
Okay. Team 1, what was the term first used by Thomson to denote hemorrhoids when he published his first master thesis based on anatomic and radiological studies in 1975? You have 10 seconds.
Venous dilatation.
Time up, sir.
Pass to
Venous
team 2.
dilatation.
Pass to team 2. 5 seconds.
Painful anal cushions.
Pass to team 3. 5 seconds.
Time.
Pass to team 4. 5 seconds.
Time up.
No?
No, sure.
Give the answer, please.
Okay, the right answer is vascular cushions. Okay, anatomically, there are 3 main discontinuous series of this, located in left lateral, right anterior, and right posterior. And each of these thick layers have a submucosa filled with blood vessels and muscle fibers, which together was collectively known as vascular cushions by Thomson. Never mind, that's okay. So the next direct question to team 2.
Yes, sir.
Okay. What deformity does this picture depict? It is a post-procedure picture and represents the anal orifice.
Anal stenosis. Anal stenosis, sir.
Okay, pretty close. Can you please give me the terminology? Time? Is it time?
Time.
Pass to team 3. What deformity does this picture depict?
Current
Time.
Team 4. Team 4.
So post-procedure stenosis pinhole defect.
Yeah, pretty close, but team 1. I need that one word. No.
Time up.
The right answer is whitehead deformity. Okay, it is a complication of excisional hemorrhoidectomy, which is characterized by skin stricture at the anal margin with narrowing of the anal lumen And at the same time, there's a prolapse of the ampular mucosa, which becomes ulcerated and bleeds. Anal stenosis was pretty close, but I was looking out for this one word of whitehead deformity. Okay, fine, no issues. Now the next question to team 3. Okay, in stapler hemorrhoidopexy, a minimum of how many circumferential purse string sutures must be placed above the dentate line? Is it A6, B4, C8, or D12? A minimum.
B4, sir.
Pass to team 4.
6, sir. Yes, sir. 6.
Sorry?
6, sir.
Pass to team 1.
8.
Yes, team 1 gets the right answer. It is C8.
By exclusion. Huh?
Yeah, good. So that's how you go. You divide the anal canal virtually into 4 quadrants, and then in each quadrant you will have to take a 2 submucosal purse string stitch, a minimum of 2, and into 4 it is 8. Okay, and once you have placed the purse string suture, you push the head of the stapler behind the purse string and approximate the stapler and fire it. End of the procedure, you need to have a good rim of tissue in the form of donut, which suggests that you have done an adequate procedure. Okay. Now, next question to team 4. In which technique are sound waves used to guide ligation of the arterial inflow to hemorrhoids? This is an easy one.
Team 4.
Team 4. Sound waves.
Ultrasound guided hemorrhoidectomy.
Ultrasound. No. Team 1.
Ultrasound guided hemorrhoidectomy.
No. Team 1.
Duple guided hemorrhoid.
Yes. Team 1 gets the right answer. It is DG Hall. It is Doppler guided hemorrhoidal arterial ligation. Okay. This is a technique where you use the Doppler, be it handheld probe or incorporated in a wireless device, which helps you identify the vascular inflow to the hemorrhoids. And once you have identified it, you can take a submucosal stitch to ligate the vessels. A minimum of 4 to 6 vessels you ligate at each setting.
You have 1 minute more, Hosni.
Yes, okay. Then we move on to the last question. That is the fastest finger question, open to all teams. Answers to go into the chat box. Come on, teams, get up. Last question. Name the enzymes responsible for the degradation of the muscle fibers supporting the vascular cushions, which in turn leads to hemorrhoids becoming symptomatic. The enzymes. 30 seconds. Yes, metalloproteinases. Shreya Shamla. That is which team? Okay.
Team 1.
Good, team 1. So it is matrix metalloproteinases. These are enzymes present in the extracellular space and can degrade collagen, elastin, and fibronectin. MMP9 is the one which is overexpressed in hemorrhoidal tissues. Okay, well played, teams.
Yeah.
Okay,
thank you so much, Dr. Nisha. Dr.
Thank you, sir. Thank you, sir.
Great, and lot of knowledge shared. So that's very useful. Thank you.
Thank you, sir. Over to
move
Dr.
on to Dr. Nishant for round 2, please. Can you stop sharing and Nishant
Yes,
coming?
So the score at the end of round 1, team 1 leads with 20 points. Team 2, team 3, team 4 are yet to open their account, but there's still a long way to go. So all the best to all the candidates.
Nishant, I will be having a time watch for you.
Yes, sir. Thank you so much. All right. Welcome to the second round. And like the trend continues, this will be from the letter from hand. And this is a slightly more higher scoring round than the first round. You can score up to 20 marks per direct question, per clinical scenario. So each team is going to get 1 clinical scenario, where you're going to have 2 direct questions, and each of these direct questions carries 10 marks, and the past answer is going to carry 5 marks. So you can score up to 20 marks per clinical scenario. Same thing with the fastest finger first. Each clinical scenario will have 2 direct questions, and both of them are worth 10 marks each, and this is only for the first right answer. The timing will remain the same. So I hope you're ready. So we'll start off with the direct question.
Nishan, before you start off, just at the end of the whenever they answer, no, just tell us what is the marks.
Yes, sir. I'll do that. I'll do that. I'll do that. So team 2, I hope you're ready. Team 2, you're there?
Yes, sir. Yes, sir.
All right. So this is your clinical scenario. A 35-year-old female patient underwent a procedure in the neck. Post-operatively, she complained of tingling sensation in the perioral region. While checking her blood pressure, this particular scenario was seen. I hope you can see what's happening to her left hand.
Yes, yes, sir.
As the cuff is inflated.
Yes,
Any
sir.
idea what that is?
Sir,
type your question, please.
Pardon me?
Question to come up.
Team 2.
Roger's signs.
Yeah, correct. But that's not the question. The question for you is, how do you manage this patient with the Rogers sign? How do you manage this patient? Your time starts now.
Sir, post-operatively, we will measure the. We will start on calcium supplements, sir.
Calcium gluconate, IV calcium gluconate, followed by oral calcium supplements, sir.
Correct answer. Correct answer. Once the patient reaches this stage, it has to be managed with IV calcium gluconate. That was the answer I was looking for. And if it's oral, it has to be with vitamin D supplementation. So 10 points or 10 marks to team 2 scorers.
Yeah. Only yes. 10 or there is one more question?
Only 10. The team 2, your second question of this clinical scenario. Name the long-term effects of this condition if left untreated. I want you to name 2 of them. Your time starts now. If you don't give this treatment, what is going to happen?
Osteoporosis, sir.
Wrong. Time
up.
Pass to team 3. Team 3.
Hypoparathyroidism.
That is what has happened, but you want, okay, passed on to team 4.
The arrhythmias.
Hypoparathyroidism. Time up.
Team 1.
Tetany, sir.
No. All right. So the answer I was looking for is what happens in chronic hypoparathyroidism is that they start having calcium deposition in rest of the body. So they can end up having renal calcification, brain calcification, psychiatric disorders, cataract, and cardiomyopathy. All right. So the next direct question is to team 3. Team 3, are you there?
Yes, sir.
So this is your clinical scenario. A 25-year-old male patient had an alleged history of injury to the palmar aspect of the left hand. You can see that the injury is here. While on asking him to flex his finger, he's unable to flex the middle and the ring finger. So your question is, which is the zone involved with respect to the flexor tendons? Your time starts now. Team 3.
Zone 2, sir.
Correct answer. The zone 2, it's also called as the no man's zone. It extends from the distal palmar crease to the middle crease of the finger. 10 points to team 3 scorers.
10, yeah, okay.
Yeah. Your second question of this particular scenario. Why is it called the no man's zone? Why is zone 2 called as the no man's zone?
There is no vascular supply.
Wrong answer. Pass to the next team. Team 4.
So because the reconstruction of the tendons will be difficult.
Why?
They retract, sir. So
no. Pass. Team 1.
No one.
Time up.
Team 2.
Sir, it can cause compartmental syndrome, sir.
Wrong answer. Wrong answer. The correct answer is there are actually a lot of pulleys.
Team 4.
I finished.
Finished.
Yeah. There are a lot of pulleys in this particular zone. So if there is even the smallest error here can lead to dense adhesion formation, it can actually compromise the result. So this terminology was coined by Bunnell in 1918. So that's the reason they believe no one should try to operate in this particular area because the results were very poor because of the complex pulley system available here. So let's shake things up a bit. This is the fastest finger first. This is applicable to all the teams. Answers to be given only in the chat box. Do not answer it out loud. The other team can hear you. So this is your first clinical scenario. A 40-year-old manual laborer hurt his hand while working. 4 days later, he has a swelling in the hand with pain and redness. Your question is, what is the anatomical specific diagnosis?
Palmar
specific.
infection,
Be
palmar
specific.
abscess.
Be specific. Specific, correct. Who got the correct answer first? The answer is thenar space abscess. Scorers, who got thenar space abscess first?
Navina.
Navina.
That is team?
Team 2, sir.
Team 2.
Team 2.
How many?
So team 2 gets 10 marks.
10 marks.
Sir, autocorrect question.
Sorry?
I had typed thenar, it became article.
No, you should be
That's not.
Okay.
Yeah, sorry, you can't
Sorry,
defend
sir.
with that.
Sorry, sir. Yes,
So the
sir,
second question of this scenario is, which space in the hand has the potential to communicate with the forearm? Answers only in the chat box. Please understand the question.
Deep palmar space.
It is a deep palmar space. I want you to tell me which is the deep palmar space. The question itself, some palmar space.
Don't say the answer. You will lose points.
Tanvi Sunil has given the right answer. It is the mid palmar space which has the potential to communicate with the space in the forearm. That's called as the space of Parona. So the answer is the mid palmar space. Tanvi Sunil, which team is that?
4 teams.
Scorers, 10 points to team 4. So we move on to the second clinical scenario of fastest.
Just check, Nishant. Shreya seems to have written Parona.
No, sir. Space of Parona is not the answer.
Not the answer, okay.
No, not the answer. Yeah, so the second clinical scenario, a 43-year-old male patient presented with spontaneous painful blisters, identifies this. Spot diagnosis. Chat box. Answers in the chat box. Pretty straightforward. Excellent answer. Tanvi Sunil, that's team 4?
Yes, sir.
Team 4, that's the correct answer. It's herpes zoster of the left hand.
Nishan, team 4 this is follow-up question.
10 points. 10 points to team 4.
No, follow-up question of the previous this thing only.
No, sir. This fastest finger first.
This fastest finger.
10 points to team 4. The second question of this scenario. Chronic pain or post-herpetic neuralgia is characterized by pain lasting for how many days after the acute infection? Chat box. 14 wrong answer, 14 wrong answer. 6 weeks wrong. Time up. 3 weeks wrong. Time up.
10 seconds.
Fine. No one gets the answer. It's 30 days. So pain lasting for 30 days after the acute infection, that's when you coin it as post-herpetic neuralgia. So let's get back to the direct question. This is for team 4. Team 4, are you ready?
Yes, sir.
Yeah, so this is your clinical scenario. The mother of a newborn noticed that the fingers of a child were fused. What is this?
Syndactylis.
Correct, but that's not your question. Your question is, name 2 syndromes which with this condition is associated with. Your time starts now.
Hello.
Yes, sir.
Edwards syndrome, sir.
No.
Time up. Time up. Pass.
Pass to team 1.
Patau syndrome, sir.
No. Pass to team 2.
Down syndrome, sir.
Pardon me?
Down syndrome.
No. Team 3.
Poland syndrome.
Apert syndrome.
Correct. Correct. Team 3 gets the answer.
Only
These
one.
are-
We asked for 2.
But they answered both, sir. They said Apert and Poland's.
Oh, sorry.
Team 3 is 10 marks, huh?
5 marks. 5 marks to team 3. It's a past answer. Scorers, are we clear?
Yeah.
Can we go ahead?
Yeah, go ahead.
So these are the following syndromes which this condition can be associated with. Team 4, your follow-up question. Are you ready?
Yes.
What are the types of syndactyly? I want you to give me the embryological classification. Your time starts now.
Time up.
Axial and parallel.
Pass to team 1.
Fifth and trans.
No.
Time up.
Team 2.
Partial and complete, sir.
Wrong. Team 3.
Polydactyly, syndactyly.
No, wrong. The answer is simple, complex, and complicated. Simple is when only the skin is fused. Complex is when even the bones are fused, and complicated when there are extra bones, ligaments, or tendons. Now, I think somebody answered partial and complete. That is an anatomical classification. It's not the embryological classification. And I specifically wanted the embryological. So no one gets the marks for this particular question. So team 1, this is your direct question. Are you ready?
Yes, sir.
This is your clinical scenario. A 64-year-old female patient underwent a major surgical procedure. She underwent cannulation in the left hand for intraoperative monitoring of blood pressure. All right. On post-operative day 2, she complained of severe pain in the left hand and the index finger. You can see that there is a little bit of blackish discoloration. What do you think has happened?
Intra-arterial thrombosis.
Correct, but that's not the question. The question to you is, what test, if done prior to this cannulation, could have avoided this complication? Team 1.
Accent, sir.
Wrong. Pass to team 2.
Allen's test, sir.
Correct answer. It's the Allen's test. Team 2 gets 5 marks. Team 2 gets 5 marks. Scorer?
Yes.
Go ahead. Correct. So the Allen's test is used to assess the collateral circulation between the radial and the ulnar artery. So team 1,
1 minute more, please.
Last question, sir. Team 1, this is your direct question for 10 marks. The second question of this clinical scenario: what is the main artery supply of the superficial palmar arch? Team 1.
Superficial branch of ulnar artery, sir.
I will give you the marks for that. 10 marks to team 1. It is the ulnar artery. In the hand, you have the superficial palmar arch and the deep palmar arch. The majority of the blood supply to the superficial palmar arch is from the ulnar artery, and the major blood supply for the deep palmar arch is the radial artery. Thank you so much. I'd like to extend my gratitude to KSCASI and the SSB for giving me this opportunity.
Thank you. Niranjan, can you give the scores?
Yes, sir. Team 1 is leading with 30. Team 2 is 25. Team 3 is 15 and team 4 is 10.
Right. I think we are going to fly right across the seas to our next round. The next round is by
Prashant, you're taking over now, scoring?
Yes, sir.
Sendil, are you there? Hello? Dr. Sendil?
Hi, sir. Sir, I'm here. I'm just trying to share my screen. 1 second.
Yeah.
I hope there's no problem.
Across the seas.
Ask Boris Johnson to help you, man.
1 second, sir. This is just giving me some problem. Oh, no.
Not working.
It's not working. I'm sorry.
Someone else can share the screen for him. So.
Nishant, you have his pictures?
Yeah, it came on, I think. Something came on.
Yeah.
No.
Score sheet.
Just the scores. Team 1 leading with 30, team 2 25, team 3 15, team 4 on 10.
Yeah, it's close. There's a lot of scopes, lot more points coming up. Okay.
Nishant, you have to stop screening, is it?
I have stopped sharing, sir. I don't have Sendil sir's presentation with me.
Sendil, are you okay, or shall we ask Dr. Niranjan to do his round and then we'll come back to you?
I think you go to the next round, sir.
Yeah. Niranjan, can you take on and do
Yes,
round
sir.
4 now?
Yeah, sure.
I think it should work now.
Okay, you're sharing then. I will hold on.
Yes, is it sharing now? Are you able to see?
Yeah, we can.
Okay.
Play your this thing.
So is all okay?
Yeah. Okay.
Oh,
Fine.
right. Okay. Sorry about that. Sorry for the technical difficulties.
So
Thank
you lose 2
everyone.
minutes of your round. You hurry up.
Okay, I'll hurry up. Yeah. Thank you everybody for this opportunity. So my round is on hemorrhage, and I'm just directly going to start to the questions. This is just the scoring. We're going to start from team 3 to team 2, and there are 2 fastest finger first, 4 direct questions, and 10 points for each answer. Fast questions give you 5 marks. Fastest finger questions give you 10 points. Again, no negative points. Okay, just moving up to the first question. So this is for team 3. Team 3, are you ready?
Yes, sir.
So team 3, so this is a historical question. So this gentleman, surgeon, lived between 1863 and 1941 from Glasgow. He's known a lot of contribution to fractures, amputations, melanoma, etc. But he's known for his singular contribution to intra-abdominal hemorrhage control, and something which is now named after him. There are clues in the pictures.
Time up, Sendal sir.
Time up. The question passes team 4.
Yes. Time up.
Team 1.
Pringle's menu.
Oh, that's, yes, absolutely right. That is James Hogarth Pringle. And we all know it. So that's just the clues were the liver injury, of course. And this is Pringle and Pringle maneuvers. Okay, so that is team 1, which gets 5 points. Okay, moving on to the next question. This is the fastest finger question. So this is open to everyone. Please type your answers in the chat box. So name this investigation, which is used to identify the source of GI bleeding.
Type your answers.
CT angiogram.
No, CT angio is wrong.
Scintillography scan, technician 99.
Scintillography scan. Yes, I think we'll give it to
Technician
Navina GS.
99.
Yes. Yes, that's absolutely right. It's
Shreya
technician.
Shamla.
Shreya Shamla.
Team 2.
Yeah.
Is it team 2?
Yes, sir.
Team 1.
Scintillography scan is valid. If you had said scintigraphy, I might agree. I don't know what scintillography is, spelling mistake. I'll give it to the team which says technician 99. Shreya Shamala.
Shreya.
Yeah.
Shreya is team 1.
That's team 1.
10
so
1. Yeah.
10 points to team 1.
Move on.
Yes, moving on. So this is a direct question to team 4. So in an accident, 30-year-old male, and there's been an RTA, he presents to the emergency department, hypotensive, BP is 80/30, contusions of abdomen, chest, right lower limb, heart rate is 94, heart sounds are muffled, patent airway, and shortness of breath with distended neck vein. Clinical scenario, like an ATLS exam scenario. So what's the diagnosis and what life-saving procedure should be performed?
Pericardial tamponade.
Yes.
Treatment would be pericardiocentesis.
Okay, yeah, that's absolutely right. I think straightforward one. So he's got cardiac tamponade, he's got dextriad, and the answer is pericardiocentesis as well. So full 10 marks to team 4. Okay, moving on. So this is team 1. This is going to be a direct question. Please look at this image carefully. It's a 22-year-old male who has a two-wheeler crash without helmet and a GCS of 4. Please look at it carefully and give me the full diagnosis.
So there's an EDH as well as an SDH. So who and counter to?
Okay, that's correct. So it's a right-sided EDH and a left-sided SDH. I'll give it to you. So they get 10 marks as well. Teams are scoring well in this round. Okay. So that's team 1, which gets 10 points. And we're just going to move forward. This is another fastest finger question. So please, again, answer in the chat box, please. So what is being depicted here? Quick. UGI, no, that's not the answer. Well, forest classification, yes. So Yousuf Khalil gets it right. That's the answer. Forest classification for upper GI hemorrhage. I think most of you all knew that, but it was just who gets it first. So the team, Yousuf Khalil's team, gets 10 marks for this. Moving ahead.
So which team is that? Sorry, Yousuf Khalil, which team?
Team 3, sir.
Team 3.
Okay, so moving ahead. So this is the last question of this round. This is a direct question to team 2. 30-year-old male with acute pancreatitis. You can see 2 arrows marked below. What sign does this represent? What's the named sign?
Sir, it is
Time up.
Greater sign.
Sorry?
Greater sign.
No, that's not greater sign. Question passes. It'll pass to team 3.
Time up.
Cullen sign.
Not Cullen sign. So you finished great runners,
Time
Collins.
out.
What is left? Next passes. It's team 4.
Fox sign.
Sorry, what was that?
Fox sign.
Fox sign.
Fox's sign. That's absolutely right. Yes. So
Fox.
Fox. So I think, is that team 1?
I request the others to not answer in the chat box, and it is not a fastest finger first.
Yes.
Somebody has answered on the chat box.
Tanvi is team 4, so team 4 gets the pass points for that.
Team 4 gets that one.
5. Timer.
I think if it is a direct question, you are not supposed to type on the box. The next person will be benefited.
Yes.
Correct.
Yes.
Some Pawan Kumar has answered, so audience should not be prompting them. They'll be able to see them.
Agreed. Yeah, this was a direct question. Yeah, just for passing, should have been answered verbally.
Yeah.
Okay.
Move on.
Move on.
So that's the end of the round then.
Hey, thanks, man.
Thank you, everyone.
Thanks,
Yeah, I made a rapid fire round.
No, but it's great to have you, Da, and I appreciate your effort and time that you've taken off your busy NHS schedules.
Thank you, sir.
How's COVID going on there?
COVID is making a comeback, but I think not as bad as it was in India. Definitely, most of the people are vaccinated now. We're all getting boosters, etc. So yeah,
And
it's
we'll
under
stop
control.
sharing.
Yeah. You take care, Da. Thank you so much.
Thank you, sir. Thank you, everyone. Thank you.
Scores: Team 1 55, Team 2 25, Team 3 25, Team 4 25. So there's a tight rush for the second spot. But let's catch the Team 1 guys. Come on, teams 2, 3, and 4. Move on to Dr. Niranjan. Niranjan is an exciting guy. He's full of videos all the time. So I think he's going to play some videos for you. Niranjan, you're playing them once or twice for each question?
Sir, I'll play them once. Probably we don't have time.
Okay, so if these videos, look carefully, he's playing it only once. So over to you, Nishan. Go to your first slide. Yes.
Yeah. Am I visible?
Yeah. Make it full screen.
Yeah.
Yeah. Thanks.
Yeah. Good evening, everyone. I would like to thank the KSCASI and SSB for giving us this opportunity. This round will be on the questions with respect to head and neck. Okay. So basically, it comprises of 4 video questions. So they are all direct questions. I will start off from the team 4, and then if they are not able to answer, the questions will be passed. The correct answers will be for 10 points, and if they are passed and then the past question is answered, they'll get 5 points. And there are 2 fastest finger questions. Direct answer first attempt will get 10 points. Second attempt within the same 30 seconds by the same team will get 5 points. Okay, so I'll play the video now. So just tell me what is going on in this video.
So thyroidectomy, sir?
I want the full answer. What type of thyroidectomy? If you saw the initial bit of this thing.
Which approach to the thyroid?
Time up. I'll pass it on. If nobody can get the better answer, I'll give it to you.
Transoral, sir.
Team
Transoral
1.
thyroidectomy, sir.
Transoral thyroidectomy.
Team 1, is it?
Yes, sir.
Yeah. I'll give you the 5 marks. I wanted that specific this thing. Okay. So it's a transoral endoscopic thyroidectomy. Okay. So the next question is for team 3. Name the procedure which is going on here. Remember, all in the neck.
Time up.
Now let the video play. Let the video play after the 10 seconds.
Okay.
Let the video be completed after the 10 seconds.
Okay.
Okay. Team 3, your time starts now.
Neck dissection, sir.
What? Complete answer. Complete answer.
Modified neck dissection.
No. What method? What method?
Up. Should be a pass.
Endoscopic.
Correct.
I'll give you endoscopic lateral neck dissection.
Lateral neck.
Okay. So team 3 gets 10 points. So we'll move on to the next question. So it's endoscopic lateral neck dissection going on.
Sir, sir.
So
Team 2 answered the
Sorry?
Team 2 answered, sir.
I didn't pass.
Okay, sir. Okay.
Sorry. I thought it's I was asking that question, direct
pass.
question. It's a direct question. Until
Yes.
unless I tell you, you shouldn't be answering.
Yes, yes.
So could I clarify who gets the 10 marks now in this for this question?
Team.
We have answered just only endoscopy, sir. We didn't answer that. We have answered endoscopy.
Sir, Rajan sir, what should we do? We'll give then the team which one answered correctly, but please answer when prompted only. Don't answer
You
in the
split
middle.
the points between endoscopy and thyroidectomy.
Okay,
Both teams
5
get
points. 5 points for each.
For which team, sir?
Team 3 gets 5 points and
Team
next
2.
was who
Team 2.
answered? Team
2.
Team 2. Okay, team 2 gets 5 points. Okay, so look at this video, team 2. This is a direct question. See the full video and then your time starts. What is going on in this video? You can see something being picked up, dissected and removed. Team 2, your time starts now.
Transaxillary thyroidectomy, sir.
So you are partly right. It's not thyroidectomy. Okay.
Time up.
Time up. Team 3.
Thymectomy, sir.
Thymectomy. No, sorry,
Team
wrong.
4.
Team 4.
Transaxillary parathyroidectomy.
Correct. You get 5 points there. It's a transaxillary approach for parathyroid adenoma excision. Okay. So it's a transaxillary endoscopic parathyroid adenoma excision. So team 1, your direct question. See the video and name the procedure. What is going on there? Since this is a short video, if nobody gets it, I may play the video again. Remember, it's in head and neck.
Play the video again, please.
Yeah. Yes, sir. Team 1. 10 seconds. Your 10 seconds have started. Team 1.
Okay. Foreign body removal from the ear, sir.
Ear? No.
Foreign body.
Time up. Pass.
No.
Pass. Team 2.
Sir, bronchoscopic foreign body removals.
No.
Time up.
No. Remember, head and neck. Team 3.
Pass.
Very fine scope, man.
Very fine scope. I'll play it again. Team 3. Team 3.
Time up. Pass.
Team 4.
So endoscopic sublingual stone silo.
What is it called? Silo?
Time up.
Lithiasis removal.
No. What is it? Okay, you're very close there. It's called siloendoscopic.
We'll give it to you. We'll give it to you. Yeah.
Okay, it's siloendoscopic extraction of salivary gland ductal caliculi. Very fine scope, probably 3 mm. Yeah.
The
So
clue was head and neck, right? It can
Okay. Yeah. So we'll move on to the next question. It's a fastest finger question. So please look into the chat box. I want you to name the procedure. What has been done here? Chat box. Answers.
Time has started. No, Niranjan.
Yeah.
Time has started. Time has started. 30 seconds. Something has been excised and repair. The defect is closed. What has been done? I want you to tell.
Written Limburg's flap, rhomboid flap, Z plus.
No,
T.
it is Romberg's flap is wrong. Limburg, what flap is not mentioned? It's not Z plus T, and it's
Time up. 30 seconds out.
Limburg flap. If somebody was close, I will give it to them.
Give it to Limburg flap.
Who was that?
Tanvi.
See, you can see how it was the flap was done in this picture. Okay, it's a case of BCC.
Tanvi, which team?
Which team?
Four, sir. Team 4.
Team 4. Okay. So the next fastest finger question. This is again one more method of closure. Name the closure technique here also. Your 30 seconds has started. If you can closely observe the end result there, shape of it.
Time up, 30 seconds out.
I'll give you 10 seconds extra if anybody wants to try.
All the answers so far are not correct. You can retry again if you want.
Retry, I'll give you extra 10 seconds. If you can see the shape at the end, somewhere there. Okay.
Okay.
So nobody is answering.
Nobody gets it.
Advancement flap.
It's a YV advancement flap. Okay.
Okay. So I'll finish the session, sir.
Yeah. Thank you, Niranjan. That's very nice. I hope your teams realize that the minimally invasive procedures have come to stay. Transoral, transaxillary, endoscopic removal of stones. All these are very useful. And catbox, some useful general surgical things that a general surgeon can do for excisions. Right. Move on to the last round, which is Manish's round. Dr. Manish Joshi, are you there?
Yes, sir, I'm there. Let's read out the scores once.
Team 1 with 60, team 4 with 45, team 2 and 3 are at 30 each. Now, please note, Dr. Manish has lots of points to offer. Over to you, Manish.
Yeah, please allow screen sharing.
You share from there, no? Share your screen. Yes.
Yes.
There we are.
So welcome to the last round, which is going to be a rapid fire round of this Dr. K S Shekar quiz 2021. All the
You have 12
answers,
minutes.
all the answers start with H. Okay, so this is, you need to remember this. All the teams, are you ready?
Yes, sir.
Yes, sir.
Yes, sir. Yes.
I'm just going to read out the instructions, and each team gets a set of 6 questions. This is not a passable round. Each set of 6 questions for each team. 10 seconds per question to answer, so total of 60 seconds. All answers begin with H. There's no negative marks, so you can swing and miss. 5 marks for each right answer. And if you are a Yuvraj Singh and hit 6 out of 6, then you get bonus 10 marks. So you can actually score total of 40 marks if you get all the 6 questions right in your own set. Clear?
Yes.
Yes, sir.
Yes, sir.
So this is a trial round. All the teams who are for this last round can answer. This is a trial round. Again,
Just shout out your answers, please. We just want oral answers, not typed. And anybody randomly. We just want you to know the way the round is going to progress.
Yes.
so the round is going to be the same, a similar set of 6 questions for each team. This is a trial round for all the teams. Again, all answer starts with H. All the best.
Thank you, sir.
Identify the surgery.
Hartman's.
Hartmann, so it begins with H. Expand HIFU. Okay, 10 seconds over.
Time out.
What is the term? A medical term for condition in which there is abnormally increased tendency to blood clotting.
Hypercoagulability.
So hypercoagulable is correct. Move on to the 4th question. Find the imbalance. Inadequate tissue oxygenation.
Hypoxia.
One of the most feared critical event during anesthesia and recovery. Hypoxia. Spotter. This is the original one. Hassan's cannula, correct. And the last question for this trial round. Hemangioma. So this will be the set of questions and answers that you will get. And you got Hartmann's, so 5 marks. You didn't get high intensity focused ultrasound. Hypercoagulable, you got it. Hypoxia, you got it. Hassan's cannula, you got it. And hemangioma, you got it. So 5 you got. So 5 into 5, 25 marks. So this was a trial round. The first set of rapid fire questions goes to team 1. Again, all answers start with H. Team 1, are you ready?
Other teams, please keep quiet.
Other teams, if you want to lose marks, you can talk. Team 1, your set of 6 questions. Total of 40 marks to get. Identify the surgery, team 1.
Halstead's procedure.
Halstead's. Question 2, expand HIDA scan.
Human immunodiacetic acid scan.
Okay. What is the term? A type of medical oxygen
Hyperbaric
therapy.
Hyperbaric.
Used to speed up.
Hyperbaric oxygen.
Hyperbaric.
Oxygen therapy.
Find the imbalance. TURP syndrome is due to excessive absorption
Hyponatremia.
of nutrients which are highly
Hyponatremia.
hypotonic due to dilutional
Hyponatremia.
hyponatremia. Spotter. Starts with H.
Pass.
Pass. Fill in the blank. Painless dash is classically associated with bladder cancer.
Hematuria.
Okay, so unfortunately you get 5 correct. Halstead's, you got it right. Hepatic immunodiacetic acid, you got it right. Hyperbaric oxygen therapy, you got it right. Hyponatremia, they got it right. It was a hemolog clip. And hematuria, you got it right. So 5 out of 6. So 5 into 5, 25 marks for team 1.
Manish, they said the human immunodiacetic acid, not hepatic. They said human.
We'll give it to them, sir.
Okay,
sure.
fine.
But it's hepatic immunodiacetic acid. So team 1 gets 25 marks.
Are you a Hubli team, man?
No, sir.
No, sir. It is not like that. It is just I was looking into the terms. That's all.
Sure.
Yeah.
Team 2, your rapid fire round. Are you ready?
Yes, sir.
Again, all answers start with H. Identify the surgery.
Hills surgeries.
Hilton.
Expand H-A-R-R-T. H-A-A-R-T.
Highly active antiretroviral therapies.
Correct. What is a term in which saline solution is a concentration of sodium chloride is higher than physiological, more than 0.9%?
Hypertonic. Hypertonic.
Correct. Find the imbalance. Late dumping in patients with gastric bypass surgery occurs 1 to 3 hours after meal ingestion is due to reactive.
Hyperosmolarities.
Wrong. Spotter.
Hypospadias.
Correct. Fill in the blank. Dash positive breast cancer tends to be more aggressive and targeted treatments are very effective.
HER2 positive.
Fantastic. Correct. So you got you didn't get Heller's myotomy. You got HART. You got hypertonic saline. You didn't get hypoglycemia. So 2 wrongs. You got hypospadiasis and you got HER2 new. So 4 out of 6. So 4 into 5, 20 marks for team 2. Team 3, your set of rapid fire questions coming your way. Again, all answers start with H. Team 3, are you ready?
Yes, sir.
Identify the surgery.
Time out.
Pyloroplasty.
Expand HIPAC.
High intensity peritoneal chemotherapy.
Okay, I'll give it to you. In which condition is the term, this phrase used? Painful bones, renal stones, abdominal groans, and psychic bones.
Hypoparathyroidism.
Okay, I'll give it to you. Find the imbalance. Gastrointestinal losses from postoperative diarrhea, vomiting, or nasogastric decompression commonly leads to
hypokalemia.
Correct. Spotter.
Hyperthyroidism.
Correct. Fill in the blank. Dash is the causative agent of chronic gastritis, peptic ulcer disease, and as a risk factor for mild lymphoma and gastric cancer.
Pylori.
Correct. I'll give it to you. So you did not get Heineke-Mikulicz pyloroplasty. You got HIPEC nearly correct, so 5 marks. You got hyperparathyroidism. You got hypokalemia. you got hyperthyroidism, and you got H. pylori. So 5 out of 6 correct. So 5 into 5, 25 marks for team 3. So the last set of questions coming up for team 4. Team 4, are you ready for the rapid fire round?
Yes, sir.
All answers again start with H. Identify the surgery.
Answered microdocectomy.
Whose?
Well, question 2, expand HAI.
I thought this was the easiest anyway.
I'm out.
Question 3, the surgical team achieves this using ligation of blood vessels, direct pressure, or sometimes use of energy sources. Hemostasis is correct. Find the imbalance. The trauma triad of death is a combination of metabolic acidosis, coagulopathy, and
Hypothermia.
correct. Spotter,
Hydrocephalus.
correct. Dash disease is the most common cause of neonatal colonic obstruction, especially in boys. Correct. So you didn't get Hadfield's microdocectomy. You didn't get hospital-acquired infection. You got hemostasis correct. You got hypothermia. You got hydrocephalus. And you got Hirschsprung's disease. So 4 out of 6, 4 into 5, 20 marks for team 4. So scorers, please add up the final tally, and we will have a rapid fire round for the audience who has been quite patient listening to this. You can use the chat box for this, put up all your answers. While the scorers do the final tally, we'll do a rapid fire round for the audience. The teams can also answer this. Anybody who's present can answer this. Again, all answers start with H. Identify the surgery. Put your answers in the chat box.
Chat disabled.
Chat disabled for audience.
All right, you can just go ahead and shout.
Go orally, please.
I've enabled it now, sir. Sorry, I had actually disabled it for the faster.
Hand assisted lab surgery.
Enabled. Go ahead. Anybody in the audience, anybody in the teams can give it a go.
Hand assisted lab surgery by Dr. Gurshantappa.
Yeah, correct.
Fantastic. So it is HALS, hand assisted laparoscopic surgery. Expand HNPCC.
Okay, next.
Okay. What is the medical term for bleeding into the biliary tree?
Hemophilia.
Fantastic. Find the imbalance. A syndrome characterized by splenomegaly, pancytopenia, which can be corrected by splenectomy. Fantastic. Hypersplenism. Spotter. What is being depicted? Boston's walls. Dash is a post-operative complication of thyroidectomy, mostly due to damage to the yes, fantastic. So answers you got HALS, HNPCC, hemophilia correct, hypersplenism, Houston's walls, hoarseness. So we come to the end of this quiz.
Thank you, Dr. Manish. That was a brilliant round. Very nice. What I liked was it was so balanced. All teams got the same kind of question. You must have spent a lot of time and lost a lot of hair trying to get that together, man. So that's the reason why I lost my hair. So getting these quizzes together. Thank you very much. Nishant, are we ready with the scores, please?
Yes, sir. You want me to share my screen?
Yeah, share.
Thank you for a wonderful quiz, all participants.
Yeah, thanks.
Thank you so much. Dr. Rajan to take over.
Yeah, thank you, guys. And I think we have a clear set of winners. The people who have finished at the bottom end is team 2 and team 3 at 50 and 55 points. Don't worry, you're not gone away empty-handed. Each team is going to get 500 rupees for having qualified. So at least you can buy yourself a good chaat or good ice cream. And runner-up position is team 4, which is the ladies team of Dr. Thanvi and her partner. Congratulations, you have come second with 65 points.
Thank you.
And the winning team of Dr. Shreya, is that correct? Shreya and Where are they on? Yeah. And Atish Shetty, you have done very well. You've maxed it quite almost with 85 points. Congratulations to you. You get 4,000 rupees. Tanvi and Sunil, you will all get 2,500 rupees. Okay. I once again express my thanks to everybody who allowed us to conduct this program and to everybody who helped me to conduct this program. I hand over to Dr. Gurshantappa to give a vote of thanks on behalf of the quiz team. And after that, we will have closing remarks by our chairman, Dr. Arvind Patel.
I think chats can be enabled again.
Enable. Yeah, you can enable chat again. Dr. Gurshantappa, sir?
Yeah, yes, sir. Yes, sir. Yes, sir. Yeah, it was a nice interaction even during the quiz. It was really, even myself, I enjoyed a lot. At the outset, I thank our chairman of KSCASI, Dr. Arvind Patel, and secretary, Dr. Chandrasekhar, for having given us the responsibility and the opportunity to conduct this quiz. And also I thank the Bangalore Surgical Society for having given the opportunity to conduct a surgical quiz. I thank our mentor, Dr. Rajan sir, for given the guidance and also given the responsibility to all of us, all the team members, sharing and giving the responsibility. And I thank for the technical support and technical help and the guidance, Dr. Lakshman K, for his excellent involvement in arranging Google Sheets and sending the link and making the students to get involved. I thank Dr. Lakshman, and I thank whole team, our team, Dr. Hosni, Dr. Manish Joshi, Dr. Nishant, and Dr. Niranjan for having involved in the team efforts for the success of our team. And also I thank all the participants and I wish them all the best. Thank you all.
Thank you, Dr. Gurshantappa. Dr. Lakshman, we need your words, man. Technical advice.
Thank you. Thank you.
We need to appreciate his effort.
Yes,
Thank you.
Then
give him a big hand, please.
No. Thank you. Thank you very much, everybody.
Very well done, sir.
Thank you.
Lakshman,
Thank
sir.
you very much. For future reference, for the benefit of postgraduates, I would like to make 2 or 3 comments. A, we have sent out a lot of mailers. There is no limitation in the amount of information you got about the design and the conduct of this quiz. I think people do not read the instructions completely, or they may not see their emails, they may not even see their WhatsApp. So please see everything, read it in detail and share it amongst yourselves in your institution so that everybody knows about it. That's number 1. Number 2, deadlines are deadlines. We had specifically said the last date for registration is 20th of November. And I actually got several calls between 20th and even this morning for facilitating registration. It is not possible to do that because it is a collective decision of the EC, the Executive Committee of the State Chapter, which is ultimately responsible for this. So we cannot take individual decisions, and we should not. Please understand, in life, particularly when you apply for jobs, apply for exams, apply for putting your papers in conferences, deadlines are deadlines. Please don't wait until the last moment or lose the deadline. Third, technology is very simple. Kindly get familiar with it. We repeatedly said that we would like you to register yourself on the on the quiz platform, and very few people did it easily. Somehow they have the problem. And fourth, again coming back, and my final comment, coming back to the answering, we clearly repeatedly said that the platform would be open for only 15 minutes. All of you understand that you have 30 questions, and unless you are spontaneously answering, if I gave you 45 minutes for these 30 questions, you look up Google and answer me. So one of the important things, and this is like an open book exam, one of the limitations that examiners put in open book exams is the time, so that you just don't have the time to refer and then answer. Answers have to come spontaneously. So at the end of 15 minutes, when I wanted to actually close the the form from taking answers, I had only 3 answers. So we actually announced again and then gave all of you 2 more minutes, and even then we got 13 answers as against 47 registered teams. So please understand that read the answers, read the instructions carefully, and be mentally prepared for this. Thank you very much.
Thank you, Dr. Lakshman. Dr. Arvind Patel, your final comments, sir, please.
Sir, thank you. First of all, fantastic program, and I am amazed at the zeal of Dr. Rajan, who is taking the responsibility of conducting this quiz. Every quiz is different. I think anyone can compare any quiz for that matter. Every year it's in a different format, and this time that too in a digital format, assisted by our scientific committee chairman, Dr. Lakshman. And as Dr. Lakshman said, though our seniors not getting tired in conducting these programs, I think I can request even our postgraduates to get involved very seriously in these programs, including the scientific programs being conducted by our KSC ASI. So, and I thank our Bangalore chapter president and secretary for this wonderful Hanumaiah Memorial Oration CSEP. As he already said, it's the legacy. So every year it's being conducted in a different style, and adding to that, these two orations mixed with clinical demonstrations will help our postgraduates and younger surgeons in a years to come. So with this, thank everyone who are getting involved in this scientific program. Thank you. Thank you, one and all.
Thank you. Dr. Chandrasekhar, you want to say anything? Secretary of the KSC?
No, sir. Actually, it has come out very nice. Thanks to Dr. Rajan sir and Lakshman sir and all the teams who have conducted this quiz program, and also Surgical Society of Bangalore, headed by Venkatachala sir and Harish. They did a very nice program. Thank you, sir. Thank you, one and all.
Thank you. Sir, you'll have to give them the formal certificates of winning at the state chapter conference at Gulbarga, sir.
Okay, okay.
These winning teams, I'll send you names and you can arrange that they receive at the opening for inaugural function of ASI.
Okay, sir.
Yes, yes.
Okay, sir. That I'll arrange, sir.
Thank you.
Okay.
Thank you.
So very well done, sir. Dr. Rajan, sir. You excel as usual. Your whole team. Now we have a breeding up a good team. Dr. Prashant, sir. Excellent work, Dr. Lakshman, sir, as usual. The whole backbone of this CSEP, the technical work, everything is done by you. And I would like to congratulate all the participants and the winners. We had some technical glitch. Hopefully from next year onwards, it will be physical. Harish?
So on behalf of Surgical Society Bangalore, I thank immensely Dr. Santosh Jan Abram, who is the Director of Academics, ASI, who is the part of this program. Dr. Arvind Patel, Chairman, KCSI, sir. Dr. Chandrasekhar S, Secretary, KCSI. Special thanks to Dr. CS Rajan, Dr. Gurushantappa, Dr. Lakshman sir for conducting this wonderful quiz session, and the team which is involved, all the faculties and all the moderators of this today evening program. Thank you, one and all. So tomorrow we are continuing with the CSEP case presentation. So anyway, we are logging. I request all to log in by 5 o'clock.
Thank you.
And tomorrow highlight is Dr. Lakshman sir is now giving a lecture on ASCII, Objective Skill Clinical Examination, Part 1 at 7 o'clock.
Okay.
Thank you.
Thank you very much.
Thank you.
Thank you and good night.
Good night.
Good night, everybody.
Good night.
Good night. Thank you.